I almost forgot. So today we're going to go over some anesthesia things, some hang-ups. I got a few things that I pulled, and then also whatever you guys also pull from what you came up with. We'll go over as well. So there's some math things, and then there's some things too that I just want to make sure you guys have a grasp concept over too for anesthesia. So please feel free to chime in as well with any questions that you have. Anything glaring out at you that you're like, I have no earthly idea what you were talking about this week on certain things.
I struggled a little bit with the ECGs.
Yeah.
I got through I got through your lecture one time, and then I went to go back and read and look over it again. And I was still kind of struggling with it.
Yeah.
So I don't know. The
Yeah.
ECGs are just, when it comes to the anesthesia, for some reason it's really hard to stick in my head.
Okay. Yeah. Yeah. We'll go over ECGs today. So and how to do like your calculating heart rates and stuff like that. It's the calculating the heart rates is actually for a lot of people can be really difficult. ECGs can also be really difficult even for a seasoned technician to know everything about ECGs, but knowing how to tell when something is not right can be definitely helpful, right? So we'll definitely take a peek at that. And then it's truly practice on looking at ECGs. So whenever anything pops up, Facebook is such a dangerous place to be on, right? All the time. But whenever things pop up and, chats and stuff like that, just kind of checking yourself on those things. And, we'll kind of play around with stuff as well as we go through. And just kind of researching what those may be. But yes, I got the record. Thank you. Then we'll do those, but making sure to know what is not normal is great so that we can alert the doctor and they can try to figure that out. Even doctors sometimes are like, I have no earthly idea what that is. We'll have to send it to a cardiologist, right? So a lot of times we only look at lead 2, especially in general practice, and even in like emergency critical care, we only look at lead 2. So that is a huge thing that we need to make sure on our monitor is that we have that set up correctly. There's always somebody that hits the button and it goes to a different lead. So that's incredibly important that we have that on there so that you are looking at the right lead. So we'll go over some of that area. So that is perfect. I think I actually forgot to include part of that lecture in there for you guys. So that may be helpful to go back if you haven't gone back to see that and review it for later so that you guys can just reinforce it later if you still are like a little shaky on it. So after today. So we'll go over a little bit on ECGs because I included some of that in my stuff for today as well. And then anything else? How were so we had a couple of videos that you guys watched where we chatted about there was a veterinary student doing a neuter. So I love Vet Ranch, first of all. I don't know why I love Vet Ranch. They do a lot of like spay and neuter, like low cost things. And I thought that video was probably good to show you the different side of things and how we may be able, going from school, you guys should have learned, right, certain things that we could or should be doing in surgery and anesthesia for monitoring and proper PPE, surgical procedures, stuff like that, which a lot of you guys pointed out for surgery in anesthesia. So what were some things, and we should keep in mind, yes, if this patient was a shelter animal, I don't know that we knew if it was a shelter animal or not. I can't remember. But
they said it was a rescue or something. A homeless one is what they said.
Got it. But keep in mind, do our shelter animals deserve or should have different standards of care?
No, they deserve the best too.
Right. So it should technically be the same. Yeah. So, right, like, it would be the same as if we, in human medicine, right, if you go to a hospital and they say, oh, what is your economic status, right? Now, do they, question mark, we don't have to open up that Pandora box right now. But they shouldn't, right? We all should have the same standard of care, right? And so should animals. We should all have the same standard of care. So it showed in a lot of those videos the difference of standard of care. I would say that in all of those videos, maybe didn't have perfect standard of care. There was probably something that we could have nitpicked out of every video that we could change or make better. I mean, I probably could nitpick in anything, right? We could always improve on something. But especially in the vet ranch video, we definitely could have improved greatly, right? So what are some things that you guys noticed?
The first thing I noticed was they masked the dog down with the gas anesthesia instead of doing like a pre-med, and there was no IV catheter.
Great.
Yeah, those were like the first things I noticed.
Those are the first things. See, Steven Satal would be so proud of you on that. Yes, very good.
Either.
There was, I'm sorry, what?
If there's no IV catheter, they're not providing fluids either.
Right, so no fluids going into the IV catheter. Great. Where were they in surrounding? Like, where were they doing their surgery?
So it looked like it could have been a surgical suite, but like a makeshift one, like a small one. And they didn't have anything on the surgical table, like no warming blanket, like circular warming blanket or whatever. They didn't even have a towel. Like, I don't know.
Yeah.
Like, I feel like that makes it harder to regulate their body temperature.
Yeah.
Yeah. Yeah, perfect. Yeah. So a huge part of it was that they had cages right behind the surgeon, right? So those are animals that could be right in your surgical suite. Yeah, it's not sterile. It's not a sterile environment. So wherever they were at was not technically a sterile environment. And yes, the videos are on Moodle for you. You'll just have to look in the discussion post where they're at, and then you'll be able to see them. And so, and they also do dentals in that area too. That's another big one. Yeah, so if you watch like other videos of theirs, which honestly I watch like a ton of them because I used a lot of them when I taught as well, and I used a lot of them not as like a negative thing or whatever, but I use a lot of them just for other things. But I think it's a treatment table. So they would bring in like a hit by car and put it on that table. So yeah, it's an interesting how they put it together, right? Now you see all different types of things within the veterinary profession. You know, there's a huge bar when it comes to how we consider a surgical suite or doing surgery or anything to that degree, right? Same thing with a sterile drape, right? There was a sterile drape, but what was it covering?
It was just covering the surgical site. It wasn't covering the whole patient.
Right. And if you look closely, at one point, now granted, I will give this doctor some grace because this was her first neuter or dog neuter ever. So, you know, like, it's not going to be perfect. It's not going to be pretty. Like, I get it. And so at one point, a huge tuft of hair from underneath the drape comes poking through the fenestrated area and is in the surgical incision spot. So then it's not covered anymore, right? So yeah, we can talk about it as an area of just maybe malpractice. Like if something happens, right? Like maybe everyone's aware of that they're doing this at a low cost, or maybe they're doing it for free as a teaching purpose, but everyone's aware that it's not best case because they're doing it for low cost or something to that effect, and so they don't have the funds to have all of the bells and whistles. They have only a small area, that type of thing. They do the very best they can. Like there could be a lot that goes to it, so we have to kind of consider those things. Yes, we could maybe set it up a little bit differently. Like, you know, could they create a curtain to close off certain areas to make it a little bit more sterile, you know, that's a little bit easier to clean, that kind of thing. There's always a way that we could have someone monitor during that time rather than relying on the beep, beep, beeping in the background. I 100% agree with the heat support concept, right? That it is very crucial during that time, especially being on a cold metal table. So I love that you noticed that as well too. So, you know, having someone as well be the patient advocate, our vet techs, think of those things too. So that's kind of what they are missing also in that video. Where's the vet tech?
I was thinking that there might have been a vet tech monitoring in the background and we just couldn't see because it mostly showed the actual procedure.
Okay.
Because at the very end, there was a guy kind of helping take the dog off the table.
Okay. Yeah, maybe. Yeah. Yeah, I'll have to actually look again and see. Yes, there's no ECG. No ECG, just the SpO2 monitor. And I have to find out as well where exactly they're located, unless somebody else realize exactly where they're located. Whether it's obviously a rural area, that kind of thing. I'm sure it's a very rural area and that whatnot too. But like I said, I mean, I truly love you know, Vet Ranch, and I think like his videos are really good for educational purposes of getting information out there, especially like he's very engaging, which is great for pet owners of how, you know, to get certain information out there so that they are aware of certain importance and stuff like that. I really do wish that we had more of the higher end practices that could have engaging real life OR looking things out there to show like what we truly do as well. So that would be really, really cool. Yes, someone should be standing there manually listening to the patient, like an esophageal stethoscope would be perfect, right? It just makes our lives easier to be able to not be in there under the drape all the time, you know, and yeah, getting down and dirty, you know, with your patient to be able to make sure that they're stable throughout that procedure. So, but no, great. That was a great conversation. I'm glad you guys noticed a lot of that stuff. Also, they were not wearing any PPE other than gloves. And his hand was like literally almost in the incision. And then you guys also noticed that the instruments were just straight on the table on their Mayo stand. So that was fabulous. So yeah, and I will say, full disclosure, I worked at a college where we had an old vet come in who wanted to just we ran out of a neuter pack for a cat neuter, and he just wanted to alcohol down some instruments and do the cat neuter. And I was teaching the surgery class, and I had to stand up and be like, no, like we are not doing that. And rather than give in to this new vet that was starting, and he screamed at me in front of the students and said, I'm a DVM and you're a CVT and all of this. And I was like, you are not touching that cat. It is not happening. I don't care. We will flash sterilize instruments, but you are not teaching my students how to do something that is unethical and wrong. Like, no, it is not happening. So yeah, it is not unheard of within the veterinary profession as well. So just stick to your guns, stick to your gut. I was going to say something. It's hard to go against the vet and what they want. It can be, yeah. You have to make sure that you have to make sure that you have a decent amount of backing. But at the end of the day, sure, their license is online, but if your hands are on that patient too, your license is on the line as well. And I've been scapegoated. So if they end up getting into a pickle, right, with a patient, you put yourself in a dangerous situation as well because you were involved with that patient, right? So
and you know that things were going right.
Yeah, and I mean, it's all about patient care. And so you have to do what you think is morally and ethically correct. You made an oath as well, right? And so you're that patient advocate. And I mean, it's sure it can be hard to go against anyone. But when it comes down to it, it isn't anymore DVM, CVT. It is DVMs have a job and CVTs have a job. And we have to work together in this industry to make a practice run. And same thing with practice manager. We all have to work together, and also CSRs. We all have to work together to make a practice run cohesively, and without one another, our practice is going to fail. And so if you were working at a practice that is going to risk your license, and they don't understand, then it's not worth working there, right? There's a way to say something to them. There's a way to say, I am not comfortable doing that. I can have something else ready, or how about we do this instead? Or, like, I don't think this is kosher, like, well, how can we fix that? But yeah, there is definitely a way. And when they own the practice, it's harder. Yeah, absolutely. So it's all about having that conversation. So, the conversation can start with, whether it's the office manager, and then also, it's about the relationship you have with the practice owner as well.
The vet who wanted to microwave fluids?
Yeah, so if they wanted to microwave the fluids to be given IV, yeah, I mean, that's interesting. So, that's a little scary. I would say, like, I appreciate, like, it's appreciative, like, I get it, but, like, oh wow, you could really do some crazy damage. I would say, I think that maybe you should do that if you really want that to be considered. Absolutely. Do an IV warmer, or even better, just wrap the IV fluid line. Like, if you do need to do it in that immediate moment, right? Because you don't have a fluid warmer, just microwave a bag of fluids or whatever, or have a hot water bath or something, and put the fluid line in it or around the hot fluid bag, so that it's just around it, and make sure that your fluid bag that you heated up is not scorching hot, but it's just like giving a baby a bottle that you microwave, but worse, because it's giving it IV, so but sometimes people in general don't think things out 100%, right? So, and it's okay. Like, we just have to be able to have these comfortable conversations. So, and trust as well, and is built over time. So you just have to build these relationships with your veterinarian, and not be afraid to have moments where you are questioning them, but also doing it in a respectful manner. So just like that, and say, hey, with the microwave fluids, could we instead do this? Because I'm just concerned that we're going to make these fluids a little too warm. So would this be just a little bit of a safer option for me? It might make it a little bit less confrontational. But yes, depending on who you're working with, I know it can be hard, especially when you're a newer technician out there. It can be definitely harder. But you guys have to be able to collaborate with your veterinarians and not feel like they're the boss all the time, and what they say goes, because I don't think that all veterinarians feel that way by any means. So they have a lot on their plate. They're like trying to balance 8,000 things at once. Sometimes they think of these ideas because they just need to fix the problem, and they do trust your instincts too. They just are trying to fix all their patients. So if you have a better idea, a lot of them are more open. They're more open-minded than you think that they are. So if that makes sense. You have to be able to let them, or give them a chance to turn you down, if that makes sense. All right. Any other Any other input?
Question, Beth.
Yeah.
You mentioned earlier that in the video or something at one point you had like a fluff of like hair that went into the surgical site. Let's say that it's like it would actually happen. Not saying that surgery and this happens. Let's say it would happen. What would be the first thing to do? Because I know on the quiz in one of them it says that consider anything that's in the surgery site as something non-sterile. So if you have something that's non-sterile that goes in the surgery site, like oh man, I don't want this to cause an infection.
Right.
What should we do?
Yeah, so I could see in the video they also later moved it out of the area too. So you'll see that now that I mentioned it, you probably look. But so what they did was they just took gauze or whatever and they like shoved it out of the way, like some of their, hopefully maybe it was sterile gauze, maybe it wasn't, I don't know, hopefully it'd be sterile gauze, and they just moved it out of the way. So sometimes your doctors will overcut their fenestration in their drapes or whatnot too. So sometimes we just have to rig it up a little bit differently by using your sterile gauze or whatever as well. So yeah, just utilizing other sterile devices to get your hair out of the way is totally fine in that regard. Now, a really big point is remember that your patient, and if anyone has had surgery before you go to surgery, you have to take a chlorhexidine shower before you have surgery. Now, your patients that come in, they don't take baths before they come and have surgery. So they're full of hair. They have gone outside and done stuff or whatever. And so in that video, they have made this tiny, tiny drape that we just put over this incision area. Okay, and so if they do that, and granted it's a neuter, all right, so we're not opening a body cavity per se, right? We're just making a small incision. And so, but if we were to open up a body cavity, so a spay, an exploratory or whatever, and we're only putting a small drape, we're actually exposing them to non-sterile areas still with the hair and everything that's not covered. So it's better to drape your entire patient then, right? So making a full body length drape and just draping the entire patient. And granted, as a technician, you have to monitor their head and all of that. We can, of course, undrape or, look underneath at their face that entire time too. That's fine. But making sure that you have a big enough drape for your patient is really important as well. Jamie, that is amazing that your doctors value your guys' input, and it is great to work in an environment where you guys can be collaborative and creative and all of that. So that's really awesome. So I mean, the more brains that you can have going, it's better patient care, right? So that's fantastic. Fantastic. I love it.
And to go back to like the
Awesome.
PPE subject, let's say you have a surgeon that is doing a surgery, is not wearing a head cap and is not wearing a mask. How would you go about saying, hey, like
you start wearing it, right?
Yeah, and then
why can't you guys start wearing them?
Yeah.
So if all of your technicians start wearing mask caps and footies, it's gonna definitely make your doctors go, why are you guys wearing them? And you'll say, it's just standard of care. Right? Or then especially gowns too, right? Gowns as well. You say, here, we've wrapped a bunch of gowns for you so you can wear them for all of your spays and neuters and all of that. It just is this nice way to introduce the idea that, hey, we have these available for you to wear, and then just have it laying out ready to go. Say, here, your gown's ready for you. There you go. You don't have to necessarily have this long drawn out conversation, or even say like, why aren't you doing this? You know, just make it available for them. Introduce it that way. I mean, sure, if it's not taken by that, you know, then maybe we can then go, you know, as to, we'd really like to do that if you don't mind, you know, or whatever. But try to make it available first and see how well it's taken. So
Another question on PPE. This might be a stupid question, but let's say you have like multiple surgeries in the day. Can you keep the same like head cap and the same mask for, let's say, if it's all spay neuters?
absolutely, yeah. So you can keep your head cap, mask, your booties you can keep as long as you take your booties off when you come out of your surgery suite. So putting them in your pocket and stuff, as long as you're not walking all over the hospital with them. Obviously that defeats the purpose. I'm a huge proponent of the fun caps as well. So like the reusable ones that you can wash and that kind of stuff. I think those are fun. But 100%, you guys can utilize those. So it makes life a lot more fun. Same thing for dentistry too. So we'll go into dentistry. Yeah, PPE shortage is crazy. So yes, getting your own mask and surgery cup is absolutely the way to go. And they can be matching if you want, or non-matching, whatever. And I'm so glad, Carla, that your doctors are super approachable as well. And they don't take things the wrong way, you know, or anything. It makes life so much easier, you know, and it sets a tone for your whole entire practice too, you know, like culture in general. You know, if your doctors are going to take things in a good fashion and a good tone, then hopefully the rest of your staff will too, right? And same thing with technicians, you know, and we just want to better our patient care and just our practice in general. And so if we find a new way or a different way of doing things that's just going to make things and elevate your practice more, then let's try it. You know, like what's the harm? If we've learned anything with COVID, we can change. And so let's try whatever we can. Awesome. So yeah, we took on a little bit of surgery today too, so that's good. But I thought that those videos were pretty cool. The toad one was kind of for fun because we don't get to see that every day. And it's again a little bit different, you know. For some animals we have to take a different approach to the way that we do anesthesia monitoring as well, so keep that in mind. For aquatics like fish, the only thing you can monitor is respiration. We can't hook up an ECG to fish. So our standard of care for that is going to be a little bit different. So great conversation on that. All right, any questions on those guys?
Oh, I have one more question.
Yeah, no, you're good.
So as far as like we're talking a bit about like shelter medicine. So about those low cost spay and neuters. So as far as like anesthesia and all that, if let's say an SPC or whatnot does not have the funds to, let's say, put an IV catheter or stuff like that, how would we go about, you know, if we know that we're being the vet tech monitoring that animal, what are the things that we can do to make sure that it goes just as smooth as possible?
Yeah, good question. So we actually have, so this is kind of I'll try to give you the short answer. So there are actually out there, and if anyone is familiar with AHA standards, right? We actually have out there AHA accredited shelters out there. So that means that there are high volume spay neuter clinics out there that adhere to all of the standards that any hospital that is AHA accredited as well. So that's pretty impressive, I think, because they are moving at super high paces and still are able to do all of that.
Lucia's ultrasound.
So,
That 1,000 I haven't transferred.
sorry. So with that, if we think about how much
from the 1,000 that I haven't transferred. Yeah.
If we think about how much our IV catheters cost, truly, it's more or less that they may not cost that much, and like it's just about how much time it takes to place them, and then the manpower to place them, right? So if we have a good amount of people that can place them quickly, we probably can do that pretty easily. Now, are we going to be able to give them all IV fluids during that amount of time? Maybe, maybe not. Or we might have stipulations on who gets fluids during that amount of time. But during the low cost spay neuter stuff, those procedures go pretty quickly. So having the IV catheter is really nice in case there's an emergency, right? So it's easier to place an IV catheter while they're stable than when they're not stable, right? So I always find it as like my saving grace. And we can always remove it then afterwards, right? So an IV catheter is pretty cheap. So I like it for that reason. Same thing with intubation, right? I always like my patients intubated. So if we can intubate our patients each time, that's great. So we have practices that intubate every single patient, and they use either a brand new or sterile endotracheal tube, right? So just think about if you got somebody else's endotracheal tube and it was just cleaned in between. So that's another interesting area that we think about. So so currently people that have the sort of regular endotracheal tubes, those are made of like PVC material. And those have to, if you are sterilizing them, they have to be sterilized in your ethylene oxide sterilizer. So not everyone has those, but they have the steam autoclaves, right? So what you sterilize with your instruments in. So they do have silicone endotracheal tubes out there that you can get. And they're just more pliable. Like that silicone ones are the ones that you get for like the really big dogs. So those really big tubes that, we use. They have those for really small animals as well. So like from size, I don't know, 2.5 all the way up. And so you can get the silicone ones. They're a little bit more pricey, not too pricey. And you can sterilize those in your steam autoclave if you don't want to throw out endotracheal tubes each time you use them. Some people throw out their endotracheal tubes each time. It just depends. But every patient should have a brand new or sterile endotracheal tube each time. Jessica.
I just have a quick question. So yeah. I've worked at a few different hospitals, and my very first hospital that I worked in, any of the hospitals that I've worked in, we've reused ET tubes. So the first place that I worked in, we would clean them with like soap and water, and then use like the little, like kind of like a pipe cleaner to go inside, and then we would let it sit in like diluted chlorhexidine. Do you know if that like goes, like sticks in that material, like if it's sitting in chlorhexidine?
Yeah, so it can definitely break it down just a little bit each time. So that's one thing. Okay. But the biggest concern is that the chlorhexidine can be a little bit irritating to the tissue for each animal. So that's one concern, obviously. And just as time has progressed, obviously, the we just have elevated in our practice of care, right? So it's not something that is, oh my gosh, you're doing something really, really bad by not sterilizing or using a brand new endotracheal tube, but it's a way to go, hey, we can elevate our way of practicing anesthesia and surgery by sterilizing or, you know, using a brand new endotracheal tube. Now, I'm married to an environmental science teacher, so I have to like try to say, hey, use the sterilizing aspect of things. Plus, long term, you're going to save more money and save the environment a little bit better by not throwing them away. But you can also, if you're, rather than throwing the PVC ones away, you could probably donate them to shelters too, because again, shelters probably could use them and they could clean them out and do it that way. Because again, like I said, it's not something that is totally awful. It's just a way of elevating your practice in the standards of care, right? Of how you guys want to practice your surgery and anesthesia. So, and you know, owners, of course, they want the best of care for their patients. And so you can just say to them, this is our standard of care. What you're getting for your patient is this. And how people pay, you know, how you guys make up that cost a lot of times, especially if you're using a brand new endotracheal tube, is that you just add that into their price on their estimate as well, because it ends up being like a couple extra dollars, especially if it's just a smaller dog or whatever, that kind of thing. So so yeah, it's kind of a nice it's a nice extra bonus end of things too, and especially for us vet techs, especially if you throw them out or whatever, you don't have to clean those really nasty ones. So I just think of the cats at least too. Like cats have such horrible upper respiratory issues. I just don't want to chance it, those guys, a lot of times. So those are one of the ones that you kind of want to ponder a little bit, like maybe that would be a good idea for cats, you know, just kind of implementing it slowly, because it's hard to make that change, especially when it costs money. Another thing, especially for low cost, high volume shelters too, was the fact of having to change gowns in between oh gosh, their surgeries. Like how many surgeries they go through a day and how many they're gonna have to change gowns in between each one. So that's like laundry galore, right? But they actually end up doing that pretty well. They found a way to make that system work really well without creating too much of a hassle. So if they're able to do it, like other practices are doing it now, they don't have to do it for cat neuters. Cat neuters are not considered a major surgery. So they don't have to gown up for those guys. So most of you guys are probably, for your cat neuters at your practice, you guys probably see your doctors doing those cat neuters blindly almost, right? In about 2 minutes. And I always say they probably could do a cat neuter with like one instrument or whatever, because they're so good at them. So, and then anyone else have, and we'll probably talk. So anesthesia wise, what do you guys typically use for anesthesia? Do you guys use any type of, for pain management? What is your typical pain management? This is my fun part.
Medicam, buprenorphine.
Okay. Ooh, Hannah, Blacks, you're my favorite. Yes, Blacks. Medicam, great. So Medicam, so NSAIDs.
We always pre-med our patients with like some sort of opioid, and then when we induce, we do like Alfax or propofol with benzodiazepine, and then they always get after, I mean, depending on the patient and their like pre-anesthetic blood work, we'll do another opioid and an NSAID.
Beautiful. So what you said that was really, really perfect was depending on the patient. So it should always be depending on the patient, right? It's great to have a protocol to kind of go off of, but it's always important that, hey, not every patient necessarily gets the same thing, right? Everyone's going to be different. So NSAIDs are fantastic to utilize, and not everything has to have opioids all the time, correct? So, so we can utilize NSAIDs quite a bit. Now, opioids definitely have their place in pain management for sure, and can be used. And local blocks are not utilized enough by any means. So wait, who said my local blocks? Who were you? Where are you? Where are you? Where are you? Where are you? So Bree said epidurals. I love that. And then Hannah, Marissa too. Okay, lidocaine blocks. Okay, and a local block on every patient. Wow, awesome. All right. So what do you guys do for your local blocks? Where? What?
Lidocaine.
Dentals. Beautiful. So, and testicular and line blocks. Great. So, bupivacaine for dental blocks, which I love. And you can do a dental block for anything. I mean, it doesn't have to be just because they got a tooth removed. It could be because their teeth are ouchy. How many of them come in with horrific teeth, right? If I had horrific teeth, I'd be like, I want a local block, right? Coccygeal blocks, yes, they're great. So that's great for, it's essentially very much like an epidural, just further down. And so it's great for cats who are blocked, like urinary obstruction. D-claw blocks. So if you guys are doing D-claws, ring blocks are fantastic too. So, or if you aren't even doing a D-claw, say you need to do a toe amputation, they're fabulous. Brachial plexus, so say you're doing a front limb amputation, or some animal broke their front leg, a brachial plexus block. And these blocks are really important as you guys grow as technicians to learn how to do yourselves so that you can provide this pain management. This is what gets really exciting when you guys finish your VTNE and then you take one deep breath and go, I'm not done yet. I get to learn more, right? Yeah, they're super easy to be able to do. They really are. And they provide great pain management because they last for a decent amount of time. And the really fun part about it is that lidocaine and bupivacaine are not the only drug that you can use in there. So like for dental blocks, you can add a little bit, and same with testicular blocks, and I'm sure other blocks too. So you can add a little buprenorphine into your bupivacaine, and that testicular block that you thought was going to last maybe like 4 to 6 hours is now going to last maybe up to 18 to 24 hours. And then in your dental block, you can add your bupivacaine or dexmedetomidine, and it's like a tiny, tiny, tiny dose. Same thing. It lasts up to about 24 hours. So what you thought was going to last about 4 to 6 hours, maybe a little bit longer, is now going to last up to 24 hours for that patient.
You said Dexter and what was the other one?
Dexmedetomidine and then buprenorphine. So either one or the other.
Okay, so you're not combining one?
Correct. I can get you, Hannah, the drug doses. For the dexmedetomidine one, I'll get you the paper for it. So if you want to give it to your doctors.
Mm-hmm.
Yes, I'll throw it up on Moodle for you guys, or what? Well, I'll throw it up either on Moodle or yeah. I give it to all of my members too, so it's fun. Yeah, I know. So but what's really cool about that is, remember, if they're in pain, it's going to delay their healing, right? So we don't want to delay healing for them, and we want them to rest. And if we are waiting for these guys, if we want these guys to heal too, we don't want them to be in pain. And what's another thing that's going to help them heal, especially after surgery, any type of surgery? What do we want them? Oh, sorry. Rest. Yes, that's good. What's another thing?
No stress.
No stress. Yes. Comfort. Good. Good recovery. If they've already received buprenex already. Great point. You just subtract out that little tiny bit of your buprenorphine dose. It's a super tiny, it's not a big dose for it. And so it can still be used in your block. Yeah. Good question, Michelle. What's another thing? So rest, no stress. What is something that
Are we talking directly post-op, like when they're in their recovery kennel, or like once they go home?
I guess both.
Okay. Temperature would play a role, like a faster recovery if their temperature is better.
Great. Yeah. What are we going to offer them that we want them to be able to do if they are in pain? They wouldn't, most likely. Food, right? Yeah, absolutely. Food. So food is going to help them, is going to give them the nutrition to heal, right? And if they're in pain, they're going to be like, no. But if they are comfortable, they're going to be like, oh, I could do this. You know, I'm all right. So yeah, we want them to eat. We want them to feel good. We want them to be, rest and whatever. When should a patient, ooh, that's one of my questions. As soon as they are recovered, is truly the answer. And so I have worked in a specialty where we gave a dog who was a GDV, totally just woke up fully, like recovered where normal temp, woke up, walked around, and we offered food, and he went home the next morning. He had surgery, late night, and then went home the next morning because he fully recovered, walked around, went outside, ate, and the doctor's like, oh, he's great. His ECG looks great. He's like doing great, and went home because he was doing so well. So, and it was truly because we were able to manage his pain. He was eating so well. He was doing fabulous. So yeah, I mean, if everything's working great, like why withhold food, right? Why withhold everything? If they're doing well, right? If they're recovering really well.
So in that sense, by recovering really well, they would be stable, like
absolutely. So if their temp is good, if they're able to walk around, then go for it. Give them a little bit of meal. Now, yes, don't give them their whole entire meal at once. So just like Maria said, like giving a small meal and monitoring, and then if they keep it down, then maybe in the next hour offer them a little additional meatball and continue to give small meals and stuff like that, and just kind of monitor them. But we also increase, and we'll talk when we get to nutrition, we'll talk about we have to increase their energy intake for them to heal as well. They don't eat just their regular diet. They have to increase their food intake during the time of their healing process. So So yeah, we also offer food the same day. Yay, good. Yeah, of course. Of course, everybody needs to eat. So yeah, I mean, we've also deprived them from food for the last how many hours, right? And so think about if you've ever been in the hospital, if you've ever had surgery, they give you food like almost, you know, pretty soon after surgery, after you recovered, right? They want to give you something. It could be broth, it could be kind of a light meal or whatever, but they give you food pretty soon after you get out of surgery. So, I mean, the first thing I asked for after I had my first daughter, literally, I was still in the delivery room, was a meal. So, they were a little bit surprised by that though, but whatever, it is what it is. So my husband was like, "That's disgusting, Beth." I'm like, "Hey, I'm a vet tech. That's what we do." So we eat in like weird places. Awesome. Okay. So we're good on that stuff. All right. So let's get to some of our math issues that we were talking about. I'm so glad you guys do use blocks. So opioids are fabulous as pre-meds too. Remember, if you are pre-medding with NSAIDs and NSAIDs only, NSAIDs take regardless to if you're doing PO NSAIDs, so orally, or if you're giving it sub-Q. Also, if you are in a different country, so I'm not sure in Canada if you can give NSAIDs IV, like carprofen IV. You'd have to tell me.
I haven't heard of it.
Okay.
I've only heard about oral and then the injectable ones.
Yeah. So, so I know in Europe, it is approved to give carprofen IV, which it still blows my mind. But it's still, if you give it sub-Q, all of that, it still takes about 2 hours to take effect. So if you're pre-medding with an NSAID, you have to give it way ahead of time. Okay. So keep that in mind.
So like how many hours ahead of time would you give it?
At least your 2 hours. Same thing with PO. Same thing with PO. So yes, so Michelle, like carprofen and your meloxicam and your Onsior and all of that, just give it. If you're only giving carprofen, if you're only giving an NSAID and you're relying on that as your pain management before surgery or any type of procedure, you have to give it at least 2 hours ahead of time to be effective for pain management. Otherwise, give something else for your pre-medication.
So you would give it as soon like when you're doing like your physical exam and all that.
Yeah.
Weigh the
Yeah.
patient and your NSAIDs. Okay.
Correct. So or have the owner give it like that morning. So that's kind of where it comes into play, where you can have anesthesia starting at home, right? Where you have people, where you have your owners giving like gabapentin at home too, prior to, or Cervenia even at home, prior to. So if anyone's using Cervenia as part of their protocol for anesthesia, which has been extremely helpful in anesthetic protocols, again, to help with any type of anesthetic nausea as well. It's controversial as a pain management therapy for surgery, but it has been really helpful for nausea during surgery. So
you would give gabapentin or Cervenia for nausea, or would you give it for like pain med like ahead of time?
So Cervenia is for the nausea. Gabapentin can be used for your anxiolytic, so like for any type of anxiety prior to surgery.
Okay.
So a great pre-medication for your cats prior to coming in, or your even trazodone you can utilize as a pre-medication for your dogs.
And
I mean,
would
and gabapentin has some pain relief too. Yes, we love our gabapentin. Absolutely.
would any
Absolutely.
of those medications like interact with other medications that you would use in surgery?
They shouldn't interact that I know of.
Okay.
Because we utilize them all the time. That's the nice part. But it's always good when something comes in that's new or whatever, double checking what you guys are utilizing. Now, here's the other thing. Always double check too what other patients though are on. So like if you have a patient that comes in and has a history of another illness, right? And it's on a medication, we have to double check, okay, well, can we give a certain medication because it may interact with something else? It's also important too, what if you have a border collie come in, or which could be the MDR1 mutant, as I call them, so we have to be careful of what drugs that we are able to give. So those type of things. So yes, knowing your diagnostics and stuff too of like what drugs to give. And this comes back into play. Yeah, white feet don't treat, right? So yeah, you're, like those certain things. So these are the things like you guys learn in school so that we're able to, again, work alongside your veterinarians. And it's there to, not necessarily catch just in case, but we're there also to be like, hey, I see we have our protocol here in place. Are you sure you want to give this protocol for this animal due to his diabetes or whatever? And then they'll go, oh, thanks so much for catching this. Let's change these drugs or whatever. But it's because you have that great understanding of it that we're able to have that better patient care. Yeah, all of our white patients are special creatures in life. That's basically what it is. They all bleed as well. They're immunosuppressed and everything. Hello. Fantastic. Yeah. Yes, that's fabulous that they are using Serenia. Oh, and omeprazole. Awesome. That's fabulous. Great. Okay, so let's take a look at let's take a look at some of our math. I'm gonna share my screen. Maybe. All right. Maybe share my screen. There we go. All right. So, do any of these math problems seem like you guys needed help with?
Yes.
All of them.
All of them. Okay. The oxygen one. Yeah. How to calculate the bag size. Yes, absolutely. All right. These are kind of the ones that I pulled out as well. So, yeah, this one was our big one that I, not our patient. Well, our patient was very big, but yes. So let's work on this one first, because this one seemed to be the biggest trouble we had. And so let's go over this one first. So this patient is 19.4 kilogram Chihuahua, or sorry, 19.4 pound Chihuahua. That is a body condition score of 9.9 or 9 out of 9. So a very large Chihuahua. He's getting a TPLO done, which we probably would not do because he's too big. We'd probably make him lose weight first. So what system would you choose? What is your oxygen flow range in units, in the correct units? What bag size would you get? So the range would you get? And what would you choose? And then what's the surgical fluid rate and drips per second? So for this one was an interesting one because first I needed you guys to tell me which system you're going to use, and then tell me the flow rate that you are going to get for his correct units. So first, which system did you guys want to use?
The non-rebreathing one.
Okay. Anyone else?
I feel like I would agree with that because it is a little bit over 7 kgs, but because it's so fat, we have to take into consideration that.
Okay.
It
Yeah.
still has little dog lungs, so we have to remember that.
Yeah, absolutely. So he was 8 point something kilograms, right? I forgot exactly what his weight, 8.8, thank you. So 8.8 kilograms, right? And so yeah, our rule was anything over 7 kilograms is rebreathing. And then under 7 kilograms is non-rebreathing. And you're right. Let's take into consideration his little baby lungs. And so also take into consideration too, he is a really obese animal that will probably have a hard time breathing under anesthesia. And the goal here is that with non-rebreathing, we can change the gases really easily, right? Like every breath is a new gas, correct?
Mm-hmm.
So I would say, yeah, that makes sense, right? And this one I was a little bit on the fence because I was like, if you can make a case either way, I'd be okay with it. You know, I wouldn't say that if you were in a hospital and someone picked the rebreathing system, you'd be like, oh my gosh, you know, like that's so wrong, you know, because it truly is like, oh, well, he is, you know, 8.8 kilograms. But I would agree with you guys. The non-rebreathing system makes sense for this guy because he does have little dog lungs. He really does. So that is great critical thinking right there. So but on the test, what would be correct? So on the VTNE, so this is a Beth question, okay? This is a Beth question. On the VTNE, they'll give you something very clear, okay? So it will be literally like a 5 out of 9, right? Of a body score condition. And something clear. So you guys will know. So you'll go based off of this right here. Okay. So don't worry about that. But then you have me here that was trying to make you think. Okay. There won't be a trick question for you. And I guess this isn't a trick question. And that's why I left it as an essay in there for you so that you guys could at least give me your thoughts. And so I would grade it for all of you, which makes a lot of work for me because there's 112 of you. So, but I did all the grading. So we have an 8.8 kilogram animal. All right. And oops. And so what is our formula for non-rebreathing for our oxygen flow rate? So we're doing O2 flow.
Isn't that like the 200 to 400?
Very good. Very good. 200 to 400. So we're doing 200 mils here, and then we'll do 400 mLs. Oh, goodness. mLs there. Perfect. So what do we get for 200 mils? It'll be 200 to 400 mils per kg per minute, Becca. Very close. Remember, our ending will be liters per minute on the flow meter. So think of that. Beautiful. So many formulas to remember, I know. So 8.8 times 200, what do we get?
We're getting about 1,700 mils, so it'd be like 1.7 liters.
Okay.
And then for the 400, it'd be like 3.5 liters.
All right, so 8.8 times 200. So this is 1760 mLs divided by 1000 mLs gives us 1.7 liters per minute. Have to always remember that. And then here, I'm sorry, here we got 3520. Divide that by 1000 as well. And we get 3.5 liters per minute. Lovely. So this is our range here. So typically what I do is I run this area as when I am doing my like induction area. Oh, I can't write. So in the beginning, when I'm inducing and when I'm inducing them, and you want to really oxygenate them in the beginning, and then this would be like maintenance. Okay. And as long as they're maintaining and they're oxygenating okay and doing well, I would leave it at the 1.7 so I don't make them cold and waste oxygen throughout the procedure. But you know that if they need extra oxygen, you can always bump it up to 3.5 liters per minute if you need to, right? Because that's their dose per se. Awesome. So perfect. The formula for rebreathing then is 20 to 40 milliliters per kilogram per minute. So it makes it really easy because you just drop a 0 in the formula.
That's the rebreathing you said? 20 to 40?
Yeah. So this one is 20 to 40 mils per kg. Per kg per minute. And then this one is 200 to 400 mils per kg per minute. Makes it very simple.
And that's
So a really good reference for like that's updated. And so I would tell you this if I wasn't, associated with AHA as well, but is the 2020 AHA anesthesia monitoring guidelines, which I posted in Moodle for you. So if you haven't looked at those yet, but it goes over like even the local blocks, there's pictures in there and stuff too. So even if you guys aren't currently doing that, that might be something to like present to your teammates and stuff as well. But it has all of these formulas and stuff in there too. I think it even has tidal volume and all of that. And then it goes over all of the monitoring parameters. It goes over how often you should be, changing out your soda line. So like how often should you change your soda line?
8 hours of use.
8 hours of use. Very good, right? Not like when it turns purple, right?
Because it will turn back to white.
Yes, it'll turn back to right. So what is a good indication, and so like what has happened before, even when I was in practice and stuff too, is that you have your end tidal CO2 that you monitor. And so what's your normal end tidal CO2 that you look at for a patient?
Usually like 35 to 55.
Good, somewhere around there. So we say like 35 to 45, but it's okay. Some animals like to hold their breath. So yeah, it could be a little bit higher. But there's also an area where it says in tidal CO2. So not end tidal CO2, but in tidal CO2. And you want that in tidal CO2 to be close as to 0 as possible, because that means that the CO2 coming into the patient should be 0. And so if you're seeing that the in of the CO2 is increasing, you have to go, where is it coming from? So many times that is coming from the soda lime canister being oversaturated of carbon dioxide that hasn't been changed out. And so I've seen that many times where, somebody hasn't been marking it off, or, it hasn't been changed out, and then we have to change it out, and then it's all better again. So yes, it should be changed out every 8 hours of use. Lovely, lovely. I like it. Good
For
job.
the ETCO2, you said it was 35 to 45?
Yes.
Okay.
But know that, and that's for cats and dogs. Now, if you are playing with other animals, it's going to change. So like for seals, I know that it's much higher because they have a dive response and stuff too. So theirs is like over 60 and whatever, but that's a whole other story. So but yes,
Let's
for
say
cats and dogs.
in the VTNE, we would get like a horse question on that, or like
That would still be 35 to 45. Yeah.
okay.
But
And
you
even
won't get something weird. They're not going to be like, what's the end tidal CO2 for a dolphin? They won't say that.
or like
I only know
correlate
that from a
it or
friend.
something.
I only know the end tidal CO2 from a friend who told me that works in a zoo. So
Like, would they ask you that for like, let's say like a rabbit or like a pig or something, or like,
no.
oh, okay.
And that would still be 35 to 45. Like, yeah.
Okay.
I mean, yeah.
I remember saying that the VTNE, like they, like medicine is medicine, so they'll ask you like the same question for like different animals. So that's why I'm trying to think.
Like all that stuff is pretty normal. I just know like those animals that have like the dive response and stuff, and the people that work in zoos have to unfortunately learn by experience, because things are many times unknown, so like we learn the basics in school and everything, and unfortunately in wild species it doesn't always work out that way. So that was something that they had to learn about seals, was that their end tidal CO2 was different, and they had to learn by just that experience. So that stuff won't be on the VTNE. Maybe you guys could teach them then. I don't know. You'd be like, I just knew that. No.
The seals was what you said?
It was like 60 millimeters of mercury was their end tidal CO2, normal end tidal CO2. So, okay. Yeah, I know. I was like, I don't want to work on seals. That seems dangerous. Okay, so now that we know their oxygen flow rate, so what is their bag size range that you'll get? So now this is like a totally separate question. So how do we figure out their bag size range?
What's the tidal volume times
tidal
6?
Volume times 6. Yay. So tidal volume times 6. And then how do we figure out tidal volume? What's tidal volume?
The weight of your patient, so that's how much your patient can breathe.
Okay. So kilograms And
Isn't
then
it 10 to 15 mils per kg?
you're close, yeah. 10 to 20.
10 to 20.
Yep. 10 to 20 mils. I mean, you might find some resources that say 10 to 15 mils per kg, but it's typically 10 to 20 mils per kg.
And it's always 10 to 20? Or is it just because we're using a particular like breathing system?
It's so yes, you should have 10 to 20 mils per kg. I'm just going based on the standards that you have. Like, I wouldn't be like, oh my gosh, you're so wrong because you use 10 to 15 mils per kg. It's not going to change your bag size to that much per se. So, but yes, our current standards that we have are 10 to 20 mils per kg. All right, so let's start with our tidal volume first, and then we'll multiply it by 6 afterwards. So we have 8.8 kilograms, and then our 10 mils here, and then our 20 mils here. So we have 88 mils there. And then we'll have down here 176 mils, right? Everybody's there? And then 88 times 6. Oh, Bree's like on it. 150, or I'm sorry, 528 mils. And then 176. Oh, she's on it. 1,056 mLs. Perfect. So if we divide these by 1,000 each to get our liters, so 1,000 mLs, we get about a half a liter here. And then we get about 1 liter here. Oops, 1 liter here. Okay. So now we have our range, and then it says, which bag would you choose? Oh no, Beth's making us make a decision, an educated decision. Yep. Bree.
1 liter.
1 liter. Okay, I didn't include this, but why? There's no wrong answer. That's the nice part.
Would the half a liter be a little too small? Because technically it was like 528.
Okay, yeah.
They say to round up.
Yeah.
I guess the more is the better for the, I don't know.
Yeah.
But it's like, instead of not having enough space, maybe
Right.
more space is better.
Yeah. Right. And we can round up. Good. The teacher said, my teacher says to use a larger. Yeah. Because we're already using a non-rebreather, and he's technically used a rebreather. So we'd like more adequate. Good. Good. Yeah. And yeah, just have enough space. It's not too much dead space either, right? So he'll have enough room to like get a full breath in. Maybe the half liter wouldn't be enough room to get an entire breath in, right? So I think a full liter would be good. So yeah, our 1 liter would probably be the best bet. We don't have to be too conservative here, so that's okay. All right. Sounds like everyone is in agreement on that. No one's super particular on a half liter. Okay, so surgical fluid rate. So 8.8 kilograms. What's our surgical fluid rate for our dog?
90, I feel.
5 mLs.
5 mLs. Good.
What's
5
90?
mLs.
Why do I have 90 in my head?
Shock rate. I was like, why did you say that? You got surgical rate yesterday, right? I was like, I'm just gonna leave that alone because I know you know it. All right, so Becca is on it. So she got 44 mLs per hour. That was so funny. I'm like, you got it right yesterday.
That's right, because I said cats are 3.
Yeah.
Dogs are 5. Yeah, I remember that.
Yeah. I was like, maybe you need some coffee or something. I don't know. Great. So 44 mLs an hour. Perfect. And now we have to do our drip rate. So we're going to set the, okay, so for our drip rate, are we going to use a macro set or a micro set for this guy?
Micro.
A macro.
Macro set, right? So he's over 7 kgs. So over 7 kgs would be macro set. So that would be 15 drops per mil. And then under 7 kgs is a micro set, and that's 60 drops per mil. And so since he's over, we can use our macro set. So here we'll do 44 mLs. And then we'll convert our hours to seconds because that's what we really want in the end. So how many seconds are in our hour?
3,600.
3,600 seconds in an hour because there are 60 minutes in an hour. And then each minute has 60 seconds. So if we multiply those together, that's 3,600 seconds.
So that's the fluid rate, right?
So we're working on our fluid rate right now.
Okay.
Yeah. So here we're going to just insert our macro set in this area. So we put 15 drops per ml. So it cancels out the mLs right there. And now we're able to figure out our drops per second because we're left with drops per second. All right. We have 0.18 drops per second. Oh, goodness gracious. What is that going to end up with? Let's see. 0.18. Becca says, multiply this by 6 seconds. So if we take 44 times 15 divided by 3,600, we get 0.1833333. So if we just leave if we round it to 0.2, we change our fluid rate slightly. Yeah. So if we just, I mean, granted, it's not going to change it super much, but especially since we're dealing with small patients, just try to not round it too much. But yeah. Because then you'll do 1 drop per 5 seconds versus 1 drop per 6 seconds. So, all right. So if we do times 6 seconds, then we get 1 drop per 6 seconds. Beauteous. Love it. Look at all those answers. And you're like, Beth, you just asked too many questions in that one question. Sorry, what is the protocol for macro and micro? So anything greater than 7 kilograms is goes to a macro set. Anything less than 7 kilograms goes to a microset. And I'd say for this patient, you could, I mean, it's right on the line, honestly. So like, I would say if you had a patient that was like 7.5 kilograms, you could just go either or. Especially since this one is going to surgery, I would still choose a macro set, because say you had to give this guy a bolus in surgery, it's easier to give a bolus with a macro set than a micro set. So just thinking more on the clinical line of, hey, you know, let's use a macro set, you know? But again, if you had to do this for a VTNE question, they're not going to give you something that's like right on the line. They'll give you something that is very straightforward. And how many GTT per mil in macro versus micro? Okay, so micros are always going to be 60 drops per mil. The standard of macro set are technically 15 drops per mil. However, certain brands have different ones. So I've seen some that are out there that are 10 drips per mil and then 20 drips per mil. So so then they'll in a problem, they'll either tell you if it's a different like one, like 10 drops per mil or 20 drops per mil. But if it doesn't tell you, just utilize the standard 15 drops per mil, if that makes sense. Why did you multiply 5 by 5 mils? So for surgery, our surgery formula is, oopsies. So if we are going off of, for fluid therapy, for surgery, dogs for surgery are 5 mils per kg per hour, and cats are 3 mils per kg per hour. So this is for surgery. Now, if they need additional fluids, they can get 10 mils per kg per hour for the first hour. If they seem like they're, you know, hypotensive or anything like that. So that's their surgical fluid rate. All right.
So if they're hypotensive and need more fluid, the max you can give is 10 milliliters per kg for an hour, like extra?
For the first hour. So this is their starting fluid rates for surgery. And then if they need additional fluids, they can go up to this. But we start our cats at a lower fluid rate because they were seeing at one point that cats were being fluid overloaded in surgery. And then dogs as well were being fluid overloaded, but not as much as cats. So this used to be the 10 mils per kg per hour used to be the standard fluid rates for surgery, and then they ended up changing it back in 2013. So that's in the 2013 fluid rate guidelines that are out there. So I'm not sure what you guys utilized for school.
But for like your added fluids, your 10 milliliters per kg per hour, you can give that for cats as well, or is it just dogs?
You can do that for cats as well. So I should actually hero that. But yeah, this is your starting. This is where you want to start.
And then after your first hour, would you stop giving it to them, or?
You would reassess. Yeah, you would reassess how your patient is and then go, okay, do we need to continue? Or are we good? Like, and go back down. So we don't want to continue our fluid rate at a high rate. And, you know, hopefully your surgery is not going super, super long, but we would reassess and be like, okay, can we back down on our fluids?
And hypotensive, meaning?
Low blood pressure.
Low blood pressure. Okay.
Yep. All right. So we want to take on this one?
Yeah, let's do it.
Okay. So we are preparing for surgery for the next day, and our oxygen, we have an H tank, and we notice that the tank has 1450 PSI left. How many liters remain? You will be maintaining your patient at 1.3 liters per minute. How many minutes will remain then? So I'm gonna get rid of this one. Okay, so our oxygen tank, so we utilize two different tanks. So our H tank is our H meaning huge and E meaning emergency, right? So both of these guys have equal pressures, right? So when they're totally full, they have a pressure of 2200 PSI in them. However, when the H tank is completely full, it has 6,600 liters in there, and this one has 660 liters in there. And so if you recall what they look like, the H tank is really, really tall, and the E tank is a tiny, tiny one that fits like on your anesthesia machine, or you can carry it around or whatever. And so when we do this problem, we have a constant that we use for the problem. And so how they figure out the constant is they take this liters and the PSI and they divide them together. So they take that 6,600 and they divide that by the 2,200 PSI. And they figured out the constant, which is 3. So all you need to know is that constant of 3. And then they did the same thing here, and they did 660 liters, and they divided that by 2,200 PSI. And that constant is 0.3, okay? So I'm just letting you know how they figured out the constant. So our constant there is 3. So now that we know those constants, all right?
Question.
Yes.
Your 220 thingy, you divide it by your liters? Is that what you did?
So yeah, we just took those two numbers, and so the 6,600 was divided by the PSI. So your liters you take and you divide it by the PSI, and so that's where they came up with the constants. So
Okay.
Yep. So our H tank has a constant of 3, each E tank has a constant of 0.3. So what we do is we go in each morning, we turn on our oxygen, and we look at the manometer, so the pressure regulator that's on there, and we see how much oxygen is left in your tank. So if any of you work in practice, you probably look at that and you're like, oh, good, I don't have to change the oxygen today. It's going to be a good day, right? And when you look at it, this one says that the PSI that's left is 1450. So we take our 1450 PSI, and then we're going to multiply that by our constant that's on that we're using. So we have an H tank. So that constant is what? 3. Okay. So how many liters then? So it's going to give us how many liters we're going to have left. Yeah, 4,350. All right. So rather than telling us that we have a full tank, which is 6,600, it's telling us now that we have 4,350 liters left, which makes sense, right? Because we only have that much pressure left. So if we're going to maintain our patient at 1.3 liters per minute, roughly, so we're just going to take an average, like, okay, we're going to average about 1.3 liters per patient, for the rest of the day, then how many minutes will remain, right? So all we have to do is take 1.3 liters per minute and divide this out. And that's going to be how many minutes we have left. So we just take 1.3 liters per minute and divide 1.3 liters per minute. And it'll give us just how many minutes we have left. So what's 4,000? So we're going to have 3,346 minutes left, roughly.
Mm-hmm.
Great. So granted, you can put that then into hours if you really want to. So then just like divide it out by 60 if you really want to. But we know at least that we have enough to make it through the day. My 1.3 came from how we're going to maintain our patients. So this is our oxygen flow rate that we're going to maintain our patients at today. So like how much we're going to use for our patients of oxygen. Does that make sense? Okay, perfect. So yeah, so when you guys go into practice, or if you're working in practice, this may be something that you can even just kind of calculate in your head or just like practice within yourself and be like, oh, okay, I can roughly average this on my own. It's really not that hard, you know, just be like, okay, we have these big tanks. How much is it saying when I turn it on? If I do the constant, and how much do I roughly, you know, like granted, we have all different sizes of patients, but how much am I going to average throughout the day? Am I going to make it through all my surgeries today? Or like, when am I going to have to change out the oxygen, right? It's super simple to do. But it's really important to do this, especially when we have our E-tanks, because you don't want to run out of oxygen in the middle of your surgery. It causes major panic and it's not fun, right? All right, so does that one make sense to you guys?
So how often should you check that?
Yeah, so typically this is a good one to do each morning when you turn it on, just to make sure you have enough that to get through the day, especially if you're going to be doing like a lot of surgeries that day or a lot of dentistries that day, especially now that we're doing like long dentistries, just to make sure that you guys are going to have enough to get through the day. Granted, yeah, been there, done that. Yeah, and it's just not fun to stress out and have to change out oxygen in the middle of a dental, and it takes a significant amount of time to change out oxygen. And your patients, what are you going to do? Like, what are you going to do in the meantime to provide oxygen to your patient? So it's just a good idea to get in the habit of doing it, and it doesn't take very long, really, when you get used to it. So but good question. That's very good.
So just to recap on that question though, we would have 3, 4, 6 minutes left in your H tank.
Correct. So you'd have 3,346 minutes. So 3,346 divided by 60. So in this case, you still have about 55 and 3/4 hours left. Because if you take 3,346, divide that by 60 minutes. So yeah, you're going to have some
55.
You have some extra time. You have about 2 days, a little over 2 days worth. So you're good. If you did surgery and anesthesia all day. Hopefully not. Hopefully you don't ever have to do that. So
good to know how to do though. It's not something that I've learned in school, so that's interesting.
Don't tell me that.
Sorry.
All right. I'm going to skip this one for now, and we can come back to that one because I want to get to ECGs for you guys. You didn't learn that either? That is like on the list. that's on like the skills list. That's so crazy to me.
We also had like a strike as well, so I think that maybe they were picking and choosing. Okay, what are the most important things to teach? I don't know.
Everything is important. No, I'm just kidding.
No, it's true. Everything is important.
Everything is important. No. I don't know. It's interesting. Okay. Where did the 6 seconds come from in the last question? Let's see. Oh, in this question here. Oh, so I'm like in this disastrous mess. So here, this is what you're talking about, right? So our 6 seconds. So we came up with this. So unfortunately, we can't give a decimal drop, right? We're not superheroes so far. We have to figure out a whole number, right? So that's where we came up with a whole number here and here. So this is where we play with our, whenever we learned it in elementary school, I say, right? Turning a decimal into a fraction. You're so funny to take me to your test, right? And so we turned a decimal into a fraction. So that's what we came up with, multiplying the 6 to turn that decimal back into a fraction, if that makes sense. And so it came close enough to making it 1 drop per 6 seconds. So it wasn't perfect, but it was almost perfect. So that's like taking like 0.2 and saying 0.2 is 1/5, because we then made that decimal into a fraction. I wonder how I would do on the VTNE. I mean, we didn't get our score back then. We just got a letter in the mail like 3 months later, I think it was. And it said, yes, you passed, or no, you didn't pass, which was so nerve-wracking. And yeah, that was it. I mean, I didn't even know what a passing score was, so, which was maybe a good thing. I don't know. So
for the 6 second thing, I thought it was 6 second because like your breathing thing was 6. But
no, it's totally different. How many times did you take? How many times did I take the VTNE? Is that what you're asking?
Yeah, I think that might be.
Oh, okay. I took it once. I took it. It's a weird story. So I got married my first year in school, and then I got pregnant my second year because I was weird. When my teachers told us not to get married or have children while we were in school because it was too much work, too much stuff. And so I was like, nope, I'm just gonna do it. And then so I was 9 months pregnant when I graduated, and I had my baby a week after graduation, and then I took my boards 3 weeks later after, I took my boards 3 weeks after I had my daughter, and then I closed on my first house the next day after I took my boards. So it was really stressful. But yeah, I was really lucky. I had a really good group of friends that there were no prep courses, no prep books at that time. There was nothing. So I had a really good group of friends that I sort of studied with and everything. So it was good. You had trouble being able to count the boxes on the ECG. I'm so sorry. They are really hard to count, honestly. So we'll do our best with that. So in order to count the ECG, we'll talk about this. So each tiny box, right, represents 1 little millimeter, right? So each small box is 1 millimeter. And so we need 50 millimeters to equal 1 second, right? So if we are looking for 50 millimeters and 1 little tiny box is 1 millimeter, 50 millimeters, that means that 10 big boxes how am I gonna do this?
You said one tiny box equals 5 millimeter.
Yeah, we're gonna, so if for our 50 millimeters, we need to count 10 big boxes to get our 50 millimeters. So let me do this. 50 millimeters per second equals 10 big boxes per second. So that means in 1 second, we're gonna count 10 big boxes. So 10 big boxes equals 1 second. Okay, so that's for your 50 millimeters.
So is that specific to that problem, or is that just like
Correct,
in general?
correct. Well, in general. So if you see one that is for 50 millimeters, you count the 10 big boxes and that equals 1 second. Now, if we have one that is 25 millimeters per second, we can count, because it's 25 millimeters per second. That means we need 25 little tiny boxes to get 1 second. We need, good, 5. Oh, wait. So 1 box is 5 seconds. No, not quite. So yeah, are the boxes always 5 millimeters? Yes, good. So that's how, yeah, perfect. They're always 5 millimeters. Yes. So they're 5 millimeters across, right? So that's why we get 10 seconds. So this might make sense. So if it's, if we're counting here, 1 box is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this right here is all 1 second worth. Okay? Because we are doing it at 50 millimeters per second. That's the speed of our tape, right? So we do it again. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Right, so that's our 10 boxes. And we'll do it again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is 1 second worth, 2 seconds, and 3 seconds. Okay, good. Now you got it. So what we're looking at here is, this is 5 millimeters here, but in this whole space here is 50 millimeters. Everyone understand that? Yep. So if we were doing 25 millimeters per second, we would count 1, 2, 3, 4, 5, and it would stop here, and this would be 25 millimeters right there. So we're counting 5 boxes, right? So 5 big boxes per second. So 5 big boxes equals 1 second. But we're not going to do that for this problem. So I'll erase that for now. All right. So the first thing you do for these problems is you're going to skip looking at this. We don't care about your ECG right away. We just want to count our boxes and know how many seconds we're dealing with. Okay. And then we are going to say, okay, we have 3 seconds right now. So we need how many seconds to get a heart rate?
60.
60, right? So we need 60 seconds. But we have how many?
So would you count each, like, however many P, Q, or ST waves are in that 10 boxes and multiply that by 60?
Not yet.
Oh.
So we don't have 60 seconds yet. Like we only have 3. You're
However many 3s are in 60 second. I mean, did that make sense?
yeah. So you're on to something. We're getting there, but we're not there quite yet. So we need 60 seconds, but we only have 3 seconds. So we need to come up with a factor to multiply, right? So it's just like when you listen to a heart rate and you only count 10 seconds worth of it. So you have to multiply by something in order to get the rest of the heart rate for the beats per minute, right? Yeah. So we need 60, so we have 3. So then we take 60 divided by 3 and we get what? 20. Good. So this is our multiplying factor for how many QRS complexes we have in our 3 seconds. All right. So it's just like, however, like you guys listen to, some of you listen to 15 seconds. So then if you listen to 15 seconds, you take 60 because that's what you need. And then you listen to 15 because that's what you have. And then you're going to multiply by 4. So you guys already do that in your head, right? So we're doing the exact same thing. It's just on an ECG. So now we need to look at, wait, you're jumping ahead. Now we need to look at PQRS and T's, right? So knowing that you have your P wave here, P wave, your QRS, and then a T. So they have to be complete ones within your 3 seconds. If they're not complete, we can't count them. So this guy, unfortunately, didn't make the cut, right? So we have 1, 2, 3, 4, 5, 6, 7, and 8, right? So we take our R waves. Oops, why did I do that? Okay, so we take our R waves times our factor, our multiplying factor, and then we get our beats per minute. So how many do we have? 1, 2, 3, 4, 5, 6, 7, 8. 8 R waves times 20. And we get 160. Yay. Do we always measure 3 seconds worth of ECG? You measure as much as possible that's on the strip. So until it runs out. So you can get the most accurate beats per minute. There are some people that only will measure like 1 second worth, and they're cheaters. And it's not accurate. It'll actually, like, because sometimes there are arrhythmias in there, so it'll throw things off. So like these are nice, pretty ones. And so you'll get a pretty accurate one, but if there's an arrhythmia in there, it won't be as accurate. So try to measure as much as you can. So does that one make sense for you guys?
Yes.
Yeah. Okay. Let's have you guys try to do this next one and count it all out. And let's talk about, and let's come up with our seconds in a second. So have you guys all do it. So remember, this is a 25 millimeter per second one, and let's count it out. Sorry, my dog's losing it. Yeah, this one might be hard for some of you guys to see too. So.
Are there 5 in this one? Are there, sorry, five boxes per second?
5 boxes per.
Wait, maybe I'm saying it wrong.
There are, it's 5 big boxes per second, if that's what
Okay,
you're,
okay.
yeah.
Okay,
Yes.
thank you.
Yeah. Oh, Brittany, you are on it, girl. Oh, Cindy, Jesus. You're like way ahead. Hold on. All right, so let's everyone ready to go over their seconds. All right, people, looks like got 6 seconds. So we need 60. Looks like we have 6 seconds. So 5 boxes per second. Very lovely. And then your multiplying factor was 10. All right, so then we get to count in here. Did you all end up counting this guy?
I did not.
You did not. Okay. Anyone else?
I did.
You did? Okay. I mean, I would count it either way. Like I would give it to you guys because it's 1, 2. So we have R waves times our multiplying factor equals, so there's 12 of these guys plus that one. So you could have 12 to 13, right? Either way, 12 to 13 R waves times 10. So that's the questionable one. So somewhere between 120 to 130 beats per minute. You counted 9 boxes per 4 seconds. There are 15.
Sorry, I meant PQRST waves, not boxes.
I'm so confused what you...
No, I'm sorry. I meant I counted the 9 waves per 4 seconds, and then I multiplied that by.
Oh, I see.
Yeah,
Okay.
my bad. I know. Sorry, I probably messed everybody up.
No, I understand what you wrote. Okay, perfect. And so that's kind of where we all come up with something a little bit different, just based on how many seconds we count too. So if you count 4 seconds versus the 6 seconds, you may get something a little bit different. So that's totally fine. I counted 14. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So this guy didn't finish right here. So if you see, there's no T wave in there. If that makes sense. Is that where everyone else thought in their 130 beats per minute? Or in 120 beats per minute? Okay.
I didn't do the first wave or the last wave.
Okay. And that's what I figured for the 120 people as well, because the P wave is almost all there. So, and I know that it's like right on the line for even the first box. So that's why I was like, I would give it to the people who put 130, just because it is, you can see it. It's just not completely there. So I would be gracious. I'd be
I have a-
gracious as a teacher.
Yeah. I have a question.
Yeah.
So I think I'm a little confused on how we figure out the big boxes per second.
Same.
Okay. Okay. So, all right. So the way that it's measured, so it's in millimeters, right? In length.
Mhm.
The little boxes, which is really hard for you guys to see. So if it were blown up, right? So this would be one big box. So what you see right here, that's one big box.
Mhm.
If it were blown up for you to see like this, inside there are tiny little boxes, and I cannot draw. 1, 2, 3. See, I can't even draw. 4. 1, 2, 3, 4, 5. And then I'm going to edit that. One, 2, 3, 4, 5. Okay. Horrible drawing. 1, 2, 3, 4, 5. Okay. So if that's a blown up drawing of it. So inside this box, there are tiny, tiny little boxes. Okay. So these little boxes equal 1 millimeter. 1 millimeter. Okay. So what it's saying there is that 50 millimeters equals 1 second when it says 50 millimeters per second is the speed. So when we count these, you could count across, if you wanted to, 50 of these little boxes to get 1 second, but your eyeballs would probably burn. So that's why we say, okay, if you do 10 of those big boxes, 5 times 10 big boxes would equal 50 millimeters to get 1 second worth. So that's how we get, up there, the 50, or I'm sorry, the second worth, if that makes sense. Does that make
And
sense?
then for your 25 in your big box, you would have 25.
Yeah, so you would end up getting, for 25, you could take 5, right? So these are 5 across, and then you would take 5 of those big boxes. So 5 big boxes, 5 times these 5 would get 25 millimeters equals 1 second, right? So that's how we continue to get multiple seconds that way, if that makes
But like
sense.
inside your big box, how many little boxes would you supposed to have?
5 across. And it's always going to be 5.
Okay, that's what I missed. So there's 5 little boxes.
So there's 5 little boxes across and then 5 little boxes down too, but you don't have to worry about them going down as well. So, but that's how they utilize for measurements.
So your 25 millimeters per second would be 1 second, right? Is that?
Yep.
Okay, so if you have 10 big boxes equals 50, and you would have, I don't know. I was going somewhere and it just kind of poof.
Yep. So, yeah, you'll count the 25 little boxes to get the 1 second, or the 50 little boxes to get 1 second, or like I said, 5 big boxes, or I'm sorry, yeah, 5 big boxes equals the 25 millimeters, and then the 10 big boxes equals the 50 millimeters, right? All to get the 1 second.
Okay. 5.
And then you keep doing it until you count out your whole strip so that you know how many seconds worth you have. And yes, I want you guys to try them all first as much as possible, especially when you grasp the concept, so that I don't have to go to your VTNE with you. Leanne.
Are
Can
these
I-
standard
Oh.
numbers?
like the 25 and the 50 millimeters per second? Are those like standard for ECG?
Yes. Yeah. So your standard in veterinary practice is the 50 millimeter per second. You usually see that the most. And then, but sometimes they'll put it on the 25 millimeters per second. So it's good to always double check on that where it's set. So sometimes you'll utilize different ones to be able to see your ECG better. So like it widens out your screen so you can see like arrhythmias better and stuff like that. So yeah, I know. So I used to help students, like even with their tests, they could have 1 minute teacher moment. And that way, you know, they could ask me a question about certain problems that they would have issues with, and I would just explain it a little bit better, or, you know, just give them a little hint and just relieve some anxiety. So I would totally do that on the VTNE. Because sometimes people just get stuck. They just get stuck on something and then it ruins them for the rest of the test. So just don't do that in the VTNE. Like if you get stuck on one problem, it's one problem. Just move on.
So Beth, I just want to recap your little drawing to make sure I understand
this
scribble
awesome redrawing right here. Like it's not even straight. Okay.
So you put 5 big boxes equals 25 millimeters, and then underneath that there's scribble that I can't read.
It's all scribble. Okay. So yes, you're 25 millimeters. So wait, you're 25. What?
You have up top beside your 160 BPM that's boxed up. You have you wrote your 5 big boxes equals 25 millimeters.
Yes. And then 10 big boxes is 50 millimeters.
Okay, that's what you wrote under there. Okay, 10 big boxes.
Yep.
And then under that you have 50 millimeters equals 1 second. And then
it's just essentially just rewriting the same stuff. Yeah.
Okay. All good.
Oh, sorry, Susan. You can. It's okay. You're cutting out. You can. Don't worry. I will definitely post this for you. I totally understand. I don't know where you are, but I'm so sorry for the rain. It's nice out here in Chicago today. Thank goodness. There's blue sky finally. Okay. Do you want a CRI problem, or do you want to do something different? CRI. Oh, you guys and these CRIs, man, you're killing me. Oh, you know what? Another problem is a quick one. I promised someone I'd go over. Let me just find it. The
hippopotamus.
Do you think there'll be time to do like the dehydration and ongoing loss and maintenance?
Oh yeah, we can make time for that.
I would appreciate that.
For sure. Everybody loves those. A patient that has 4% isoflurane is on a 4% isoflurane. 4% iso.
That's a CRI.
No, this is inhalant gas, right? We'll do this before the CRI. And they're on an oxygen flow rate. You guys might remember this one. A flow rate of 1 liter per minute. How much oxygen? How much? Stop, crazy phone. How much oxygen? How much O2 will your patient get? Will patient get per minute? And how much ISO will patient get per minute?
So this is not the problem where it's calculate an appropriate rate. That's a separate thing.
Yeah, this one, so this is a different, we'll do this one next, but this one, I promise someone we go over.
Okay.
So I want to make sure we do this one first.
Got it.
So yeah, or calculate an ISO, yeah. So, oh, and the MAC. Yeah. So do you remember this one at all? This one was a question.
Yes, but I literally didn't even know how to go about it.
Yeah, this is crazy. So, so when we deliver ISO, this is important to know because when we are delivering isoflurane, we don't just set the vaporizer and just deliver 4% isoflurane. That's the same the entire time, right? It changes when we are using our oxygen flow from our flow meter. So it's important to know how much actual ISO we are delivering, right? It's not just set by our vaporizer. So this one is to show you guys exactly how that's calculated. And I'm so surprised you guys didn't learn this too.
So your
Gosh,
question
now I know why my anesthesia class was so hard. So here's the question, right? So if we are delivering, and it's super easy to figure out once you guys know it, if we are delivering oxygen flow rate of 1 liter per minute, how much of each essentially will our patient get? So our oxygen goes through our anesthesia, but where does the oxygen go to? Does it go through anything else?
It goes through your ISO.
Correct. It goes through the ISO, right? So it has to pick up the isoflurane. So our oxygen is mixed with isoflurane, right? So we are not just delivering pure isoflurane. So we are essentially delivering 1 liter per minute of gases to our patient, right? And so now we have to say, okay, if our patient is getting 1 liter per minute of gases, total, what is it that what is the isoflurane and then what's the oxygen? So how do we figure that out? Maybe we can convert some things first.
Is the percent the same as like how Baytril is like 2.27% is like the 22.7 mgs per mil?
Good thought. Yeah. And we don't have to go that route actually. So remember when we're delivering this gas, we're giving a percent of the gas to the patient. So it's not necessarily a dose that way, but we're giving the patient 4% of the patient's gas to that patient. So not necessarily like a milligram dosing, if that makes sense.
But your percent, your 4% would be 0.4?
No. So if we are giving 100% gas to our patient, right? 4% of the gas, 4% of the gas is isoflurane. Does that make sense?
Mm-hmm.
So how do we figure that out? And the total gas is 1 liter per minute. %96 is oxygen, yes. So how do we figure that out?
So 96 minus 4.
So 96% is oxygen. So, and then our total here is 1 liter. So how do we figure that out in saying, okay, what do we get per minute?
You turn your gas into liters?
Yeah, we could do it in liters. Absolutely.
Because your ISO is fluid until it's exposed to air.
Yeah, we could turn it into liters or milliliters or whatever. Absolutely. So how do we do that?
Did you divide it by something?
So let's do 1 liter. How do we figure out a percentage?
1 liter on 100?
And say we want to figure out how much oxygen. So because I have it right there. How much oxygen from that 1 liter are we utilizing? Do we multiply or divide?
Do you have to make it into a fraction? I don't know. I'm confused.
For the 96, you could turn it into the decimal times 96, right?
Decimal.
So how much? Yeah, you could do a fraction that way too, of course, if you wanted to. Yeah, if you're a linear person, you could do it that way. So if you're a linear person, you could turn it into 1,000. Oh goodness, I can't even write 1,000 mLs, and then do 96 over 1,000 or something. If you needed to do it that way, I don't know, but you don't have to get that crazy, right? So what's 96% of a liter?
0.9. Oh,
Zero.
wait, I did that wrong. Oh, 0.96.
0.96 liters of that liter, or 0.96 liters per minute, remember, right? 0.96 liters per minute is of oxygen, right? And then how do we do then our isoflurane?
We do the same thing.
Times 0.04 is 0.04 liters per minute is ISO. Now, this is where it gets tricky, right? Because you guys are like, this is so stupid. Say we have our patient on 4% ISO, and we change our flow rate to 3 liters per minute. Okay. And so we're thinking, right? You know, oh, no big deal. Like it's on 4%. And, you know, we are just going to like OD our animal on oxygen because what's the big deal, right? And he's just on 4% because we just do that. I don't know. So what happens is that we do the same thing, right? 3 liters times that, what?
0.04.
Our patient is, okay, you want to do your ISO first, right? You're going backwards on me here.
Or your oxygen. Keep it.
So,
through 0.96
Okay, perfect.
oxygen.
Equals, so 3 liters times 96 is what?
Times 2.88.
2.88 liters per minute of oxygen. Okay, oops, I'm like typing away here. And then 3 liters of 0.04 is how much ISO?
Where did we get the 3 from?
We turned up our oxygen. Or someone turned up the oxygen. Say your doctor turned up the oxygen. Oh my gosh, this happens all the time. They come by and they're like, let's turn up the oxygen. And then you're like, no, leave my anesthesia machine alone.
So 0.12 of the ISO.
0.12, you said?
Yeah.
Liters? Okay. Of ISO. So it doesn't look like a big deal, but like if you turn that liters into milliliters or whatever, that's a big deal. And it's a huge jump. It's 3 times as much, right? So, and you haven't changed your ISO, right? You have only changed your oxygen. So just keep that in mind that even when you turn down your patient from even if your patient's too deep, even evaluate your vaporizer and then also evaluate your flow meter too, right? So you could be overdosing in multiple different ways. So that's a really good concept to think about.
How do you overdose on oxygen?
Oh my goodness. Well,
That's a thing?
yeah, actually, you can get
Really?
oxygen toxicity. Yeah, absolutely. Yeah, if you're on oxygen for over 24 hours, you start getting oxygen toxicity. Like if you're on 100% oxygen. Yeah. Also, what I'm saying, like, too much oxygen, granted, like that here we're wasting oxygen, number one, potentially, right? Your patient could get cold. They're not needing this much oxygen. And we're having negative effects here by having 3 times more than what we had here. So if your patient is just too deep, yes, we need to evaluate your isoflurane, but also evaluate your oxygen flow rate, because that could be a potential negative effect too with making your patient deep as well, because you're pushing out more isoflurane than you may want to. So, yeah. All right. There's so many things to look at in anesthesia. That's what's really cool about it. And yeah, I know it makes especially some technicians really scared, but it's good.
Sure.
All right, Becca, sorry. Have a great day. Good job today. Okay, so calculating your rates for fentanyl, lidocaine, CRI. So fentanyl is what do we use fentanyl for? Or what is fentanyl?
Opioid.
Opioid, good. And it is what kind of opioid?
I feel like it's a mu something.
A mu, yeah. So it's a pure mu opioid. So that means that it hits the all receptors. It is a Schedule 2 controlled drug, right? So highly abused drug. Super potent as well. So 100 to 250 times more potent than morphine. So yeah, we keep a good close eye on that guy. What is lidocaine then?
A block. Analgesic.
Yes, it's a local anesthetic. Awesome. Fantastic. Okay, so I like to quiz you on that. So we have the CRI that we're going to use. We have the doses available to us and our remaining fluids that are there. with our fluid rate. So bye, Leanne. Have a great day. We're gonna finish this up and probably call it quits. So see you next week. So what are we gonna do first? Looks
See
like
how many hours you have left.
Perfect. Good. So we have 273 mils left in our bag. So how are we going to figure out our hours that remain? Or I guess
Divide that by 53.
Good. Divide by 53 because that's our fluid rate. And how many hours then would we get?
About 5 hours left.
Perfect. Everybody get 5 hours-ish? Yeah?
Did 273 divided by 50.
Oh yeah, I got
Yeah,
5.15 hours. So if we have that, looks like we're gonna need minutes too. So how do we figure out our minutes then?
Divided by 60.
Not
Didn't
divide
you
by
multiply by 60?
perfect. Multiply by 60 to get our minutes, right? Oh, sorry.
So it's your 5.15 that you multiply by 60?
Yeah, so I just kept the decimal here. Oh, sorry. My husband is coming. There. My new puppy is like super barky. Okay. Yeah, so we're gonna multiply by 60 to get our minutes. So we got 300. So I'm gonna take out this decimal just to make it nice and pretty. So because it was 309. You guys want to keep the 309 or take it out? Looks like some of you keep it.
Could you do 5.2 instead of 5.15? Would that help?
All right, so we have the 309. You're like, keep it. Okay, so we have 309 minutes.
309, okay.
All right. So that's our minutes. Here are our hours. So we have that. All right. So we have time. So time is good. And then we have our kilograms already because someone was nice and gave us kilograms. Maybe I just decided to live in Canada that day. So there are some practices that strictly work on like kilograms and I worked at one practice that only did kilograms. So I was like, this is great. So now we get to work on fentanyl. Oh, you only have kilograms there? Fantastic. I want to work where you work. That's awesome. Fentanyl. And then we have a lidocaine to work on. Awesome. I like want to go work at all your practices to see what you guys do. That would be so fun. I'd probably bother you guys so bad. So our dose for fentanyl would be, we have 5 micrograms. I'm like actually ridiculously fun to work with. At least I say that, but I bother literally everyone. So it's really funny. And then, so 5 micrograms per kilogram per hour. So we have.
What's UG?
So UG, so you have, it looks, when you write it, it looks like this, UG. It's literally the same as micrograms.
Oh.
Yeah. Mind blown. I know. Isn't that nuts? I don't know why. I don't know why they decided to do that to us, but they did. So yeah, interchangeable.
UG equals micrograms.
Yep.
Cool.
Just to throw us off and make us want to cry. So then we take our 14 kilograms, put that in there. And then last thing we need is our time. And for fentanyl here, we're going to use hours, right? So our hours is 5. Oh, goodness. Beth needs to write better. 5.15 hours. And we are done with our dosing in there. So let's do our calculation for that guy.
Where does, oh, I was gonna say, where does the 14 come from? Right there, the dog's 14 kilograms. All right.
Great. Hannah and Kenya and got 360.5. Bye, Jessica. Thank you so much. I know we go
Bye,
so late all the
everyone. Thank you.
time. We go so late. All right, so this is still micrograms. Awesome. I know we go so late all the time, but I feel like you guys just
Soak it
want
all
it
up.
and need it. Yeah, so it's great. Awesome. Hannah, you are like on it, man. All right, so we are still in micrograms and our fentanyl is left in micrograms. How nice is that? So we don't have to do any conversions on this. So we take 360.5 and then we are going to divide that by our concentration of 50 micrograms. And then we get, Hannah says 7.21. So we'll do 7.2 because that's what we can draw up. Hopefully you guys can read all my writing because it's nuts. I am not a good writer at all.
360. Oh, and then you're dividing. Okay.
Divide by 50 because that's the concentration right there.
So 360.5 and divided by 50. Okay, which is your concentration, right?
Yep. And then we are going to add that 7.2 mils into our bag of fluids. All right, so our lidocaine will start. So our lidocaine dosage is up there. Yeah, Amanda, let's try that ourselves. Good. So put that in, and then we'll have you guys let me know what that looks like. Good idea. Oh my gosh, my little birdies are trying to fly themselves. I just love it. You guys are so independent too.
I got 4.3 ml.
I did too.
Oh, for lidocaine?
Yes.
Oh, you guys are fast.
So for the, I'm stuck. So for the lidocaine, if we're doing the same thing as fentanyl,
I'm gonna have Jatara. She's gonna walk me through it. So,
Okay.
cause she spoke up first.
Okay.
that.
She's like, oh no.
No, so what I did for lidocaine was I did it in the beginning. I converted the micrograms into milligrams,
Okay. So
which I
what
got
yeah.
0.02.
Okay. Milligrams. Awesome.
And then I put that into the formula. So I got times 14 kilograms.
Okay.
Times 309 for the minutes.
Awesome.
And then I got 86.52.
And that's milligrams, yeah?
In milligrams, yes.
Perfect, okay. And
then I divided that number by, well, okay, so the 2%, I know you don't like it, but for me, I dropped the percentage and multiply it by 10.
Okay. As long as you know what it means, I'm good with that.
I know it means grams per 100 mLs.
Perfect. I love it.
And then I got 20 milligrams per ml. And so I divided 86.52 milligrams by the 20 milligrams per ml. And then I got 4.3.
Lovely. Good job. Look at you, the CRI queen. I love it.
It makes so much more sense now.
Good, good. Fantastic job, guys. That's great. Awesome. Look at this. You guys are going to love math now. My goal in life, create people that like math. Just like math. Let's just say that.
Tolerate it.
Tolerate it. I like it a lot. I'm like, oh, okay, we could do it. Okay, so parts of the anesthesia machine that are not included in rebreathing circuit. Let's try that. Let's finish that part at least.
So the line.
Yeah, so the CO2 canister or whatever, right? Yeah, carbon dioxide absorber, CO2 absorber. That's the word, absorber. Absorber. Vibrate. Yeah, we're just gonna finish this and we're done too. So thanks so much.
Manometer.
Manometer, yes. Everyone says that too, so don't worry. Manometer, yeah.
In French,
Perfect.
it's manometre.
Oh, yeah. Perfect. So the manometer, that's like for the bag, which I hate because I wish that we had one for the non-rebreather, because I'm always like, oh my gosh, you're gonna pop their lung, I swear. I'm so nervous. So
The
perfect.
Bain system has one.
Yeah, absolutely. Yeah. But not the non-rebreather. Yeah, not the manometer though. Or I mean, not the non-rebreather doesn't have one. What else? There's certain, ooh, good, exhalation valve, yeah.
Rebreather.
Exhalation. How about insulation valve?
Oh. Exhalation, insulation valve.
Or inhalation valve. Inhalation valve. Those are the big ones that I'm looking for. So that is for the non-rebreather. So rebreather has all of these that the non-rebreather has. So we split those apart. Good job. All right. So this is part of that one quiz. We have a manometer for our non-rebreather. Really? That's nice, because we didn't have that. I have to look at that, because it always, you guys are, well, then somebody fixed my issue then, which I love, because I was always nervous. We never had that. So this one right here is part of the quiz where everyone, I was like, are they just defying me and not wanting to do this? Or it looked like, now I know that you guys just didn't have enough time to finish it. So I will go through and make sure you guys have extra attempts so that you can go through and think about these and fix all, and do all of it. So I'm like, they just don't want to do it. But this helps with knowing exactly how to put together an anesthetic machine, and then figuring out, especially if someone else has taken it apart and not put it back together correctly, which happens so frequently in practice. So not to try to make your life totally miserable, but there's a method to my madness, I swear. So for the question of lidocaine, do you have to convert to milligrams, or you could leave it? You could totally leave it to micrograms if you wanted to. Where did I have my? So if you left it to micrograms, you just would have to convert this to micrograms to finish it, if that's what you did, and that's totally fine. So then you would take your 2%, convert that to your 20 milligrams per mil, and then convert it again. Perfect. Yeah. Yeah, it's totally up to you. As long as you know your conversions, you guys are good, which I love that you guys do. Awesome. Any other questions before we head on out today? Oh, we had dehydration.
Beth, there's still all the practice math things that you still have in the file section of VTNE prep, right?
Yes, yes.
Okay.
Yeah, there's the dehydration stuff too. I know you had a question on the dehydration as well, one of you guys. Do you want to do that one before we leave quickly?
Yes, please.
Okay.
Yeah, that was me. Sorry to
Oh,
make
no,
you
it's
guys
totally
stay
fine.
longer.
No, whoever wants to stay, that's totally fine. If anyone else needs to go or whatever, definitely I'll do one of those problems and then we can head on out. So it's no big deal. I'll just make up something. So say we have a 26-pound dog. Where are the conversions at the VTNE prep? So conversions, there's a few different ones that you can utilize. They're all in the file section. So in order to go to the file section, you just have to go to the top bar and oh goodness, it's let me just make sure I'm telling you exactly the right clicking part. And so if you go to the more section, all the way down, maybe I should share my screen and show you. Oopsies. Stop sharing. Share this. Okay, so you guys can see the VTNE prep. Yeah. Maybe.
Yes.
Okay. I'm like, I can't see your chat. Okay. So if you go up here and you go to more, here's like media files. So if you go to files, it'll give you all of these files that have been placed in here. So you can have like a field day and all of this stuff. There's like quizzes in here. Like the anesthesia flow chart and stuff is in here. Formulas, like the new formulas stuff is in here. There's the conversions. There's these conversions that I just put in here as well. And then also in the more section, if you go to media and then go to videos, you will see a bunch of the videos that I've done over time. Here's like a math one I know that I did. Pain, here's the ECG one. Emergency is one. CPR, dentistry. There's a couple math ones that I've done too. Nutrition, stuff like that. So yeah, check those out as well. And then lastly, a little bit more organized one would be go. In the guides section, it has just the very basics of pharmacology, anesthesia, like all of this stuff. So,
wow.
So that way there's some like assessments that you can do, acid-based things, dentistry, large animal review. These are just things that kind of I started before the crash course, but they're different practice tests and stuff like that. So just a little bit extra things if you guys are looking for. Okay. So yeah, check those out as well, if that's helpful.
Definitely. That's going to be my goal for the week, is go in there.
Yeah. Yeah.
I'm
So
only 3 weeks away of taking the exam.
Yeah, definitely. I mean, there's a lot in there for sure. And I keep trying to add in there too, because I want to make sure that everyone gets something. You know, and it's not just you guys, but I'm definitely wanting everyone to get a little bit of something. So, all right. So, for this guy, we have a 26-pound dog who is 8% dehydrated. And he vomited 2 times. Oh goodness, 3 ounces, and diarrhea 1 time, 3 tablespoons. The doctor wants to DVM. Oh no, DVM wants to correct over, let's see, 18 hours. So let's go that way. Let's start there. So first, what we're gonna do, so we figure out our dehydration, right? Then we're gonna figure out our ongoing losses. Let's do that. It doesn't like me. I'm getting rid of it. Ongoing losses. Why do you do that? Ongoing losses. Oh, is it? Geez, ongoing losses. No, it's like deleting it. Why are you doing that? Oh my God. That's weird. My computer's being weird on me. Okay. Ongoing losses and then maintenance. Okay. So when we figure that out, then we will figure out the total of those, right? So we'll do our total of that. And then we'll figure out our maintenance rate. So get rid of this guy. All right. So for dehydration, let's start with getting our pounds to kilograms.
It should be 11.8 kilograms. So like 12 kilograms.
Perfect.
And then you're vomiting. You vomited 2 times. So 2 times 3.
So we're gonna do dehydration first. So let's stay with that for a second. So
turn your percent to a decimal.
Perfect. Great. So we'll do, we have 11.8 kilograms times our percent to a decimal. So it's 0.08. Oh. Are you guys seeing the 8 in there, or did it go away?
It went away 0.
Oh, it's being bad.
0.08.
Yeah.
Could you just type it up?
There. I think it's just the program's being really glitchy. Okay. All right, so 0.08 times, and then what is the finishing part of our formula?
Times 1,000.
Times 1,000. Very good. And so what do we get for mLs?
944.
Perfect, 944. Awesome. So that's the first part of our problem. Okay, so now ongoing losses. So let's do vomiting first. I like to break it down. So vomiting. So he vomited 2 times, right? So vomited 2 times. So 2 times 3 ounces. So 3 times, how many mils are in an ounce?
30.
30, good. Oh my gosh. 30 mLs. So, let's do order of operations. So 3 times 30 is
90.
90 mLs times 2 equals
180.
180 mLs. Now we get to do the diarrhea part. So diarrhea is 1 time 3 tablespoons. 3 times how many mils are in a tablespoon?
15. Yeah.
15, good. 15 mLs. So order of operations, 3 times 15 is 45 mLs. All right, so that's 45 mLs total there. So now we just add these guys together, right? Because this was his diarrhea. So we take 180 ml plus 45 mLs. And we put those guys together. How much is his ongoing losses?
So
225.
The 180, is that his vomiting?
The 180 you said?
Mm-hmm.
Yes. So this is vomiting and this is diarrhea.
The diarrhea went 2 times. Where does the 15 come from?
It comes from tablespoons.
Oh, one.
Okay, so maintenance. So maintenance rate for a dog.
The 20.
How do you guys do your maintenance rate for a dog? There's a couple of different ones. I can introduce you guys to a new maintenance
per kilogram.
rate. Okay, so we could do 60 mLs per kilogram per day. I can introduce you guys to a new one if you'd like. That does body surface area. You guys are like, oh my God, Beth, no. So the new one is we would do let's see. Let me just make sure here.
It's super glitchy from my end, is it?
Yeah, I'm hearing some buzzing.
Mm-hmm.
So have you guys heard of the body surface area fluid for fluids?
Nope. For maintenance, right? Is that the D is dehydration, O is ongoing losses, and M is for
What? Huh?
maintenance. Okay, thank you.
So I'm just copying and pasting something really quick so you can see it. Oh, why does it do that? This 3 should be multiplication here. Delete. I think my computer's just like a mess. Why does it do that? So this formula should be this part right here should be gone. It's not. That should be a multiplication. Oh my gosh. Why is it doing that? Multiply. There. So that is the dog one. And this I'm putting in here is the cat one. Like, you guys are gonna be so smart.
So that's a formula for the fluid maintenance.
Yes.
So the first one
And
is
I'm gonna
dog.
show you guys how to do this one really simple.
So the 132 is dog, right? And
Yeah.
then
And then this one is supposed to have a multiplication in there, but my computer's being dumb. Okay, so for the dog one, this is what you do. All right, and now this is how you compute it in your calculator. You would take, oh goodness, you're gonna take your kilograms in parentheses times kilograms times kilograms in parentheses, okay? And then you equal that out. So you equal it. And then you square root it. And then you square root it again. And then when you're done with it, don't equal it. You multiply it. Oops, that was me. That's totally my fault. And then you multiply that by 132. And then you equal that. And that is your fluid rate for the day, for mLs per day. So this is the most accurate. This is the most accurate mLs per day. This is the most accurate fluid maintenance rate due to the fact that this is for body surface area. So this is something that you may see more in practice. So let's try this one for this problem, just so that you guys get used to it, because you may see it more often in practice now. You may still see this quite frequently in practice, the 60 mils per kg per day, and that's totally fine. But more and more, we're starting to see this in practice. And so I'm not sure if you guys were taught that in school. Anyone taught that in school?
nope.
No? Are
No.
calculators allowed in testing? Absolutely. And so you will have access to like your phone kind of calculator, you know, like your iPhone kind of calculator, with the opportunity of something where it's turned to the side, and you can utilize the square root function on there, if that makes sense. I was only allowed a plain calculator. There should
Holy
be
cow,
a
this is
square
worse
root
than
on
a
there.
CRI.
You should have a square root function on there.
So the kilograms you multiply 3 times.
Correct.
Square root times 132 gives you your maintenance rate.
So that's a kilogram
Yeah.
of DN per se. So let's say we have our, was it 11.8? We do 11.8, 11.8 times 11.8 3 times.
Correct. So you do 11.8 times 11.8 times 11.8. So what do you get total right there? I got 1643.
Got that too.
Awesome. So now you're going to go and do your square root function. So your square root function on there would be, it says 2 on the outside, square root x. Did that?
I don't have square root.
No? Are
Not
you
on my
using, like-
little one.
Oh, not on your, okay, perfect. Yeah, and so like this might not be something that you need for the VTNE per se. You could still use your 16 mils per kg per day. It's going to come reasonably close to, but this is something that you guys just be aware of for when you're in practice as well. Okay, so square root it twice. So once, and then again, and so you got 6.36. Leave it like that. Just leave it. Don't like do anything. And then multiply that by 132. And then hit equal.
So 8.
Yeah, don't round out. Just leave it the way it is. It doesn't. Yeah, it's not gonna matter too much. So what'd you get?
840.
840. Good. 840.3 or 4, whatever.
40.4 if you round it
Okay,
up.
sure. Okay, so if we did, interesting enough, let's see. Let's just play. So 11.8 times 60 is 708. So it's a fairly decent difference. You know, 140-ish mils a difference if we did the other way. So that's why I think it's interesting how we do it. All right, so now we go back to the kind of the way that we have been doing it. So now we need to figure out our maintenance for the time that we are going to do correction, right? So what would that be? How do we do that for this guy? Because we're not going to do maintenance on this guy for an entire day. We're only going to do it for the time that we need to do his correction.
So you would do, say, body weight.
So let's break this down a little bit. My paper says we can only use calculator on computer. You're right. You can only use a calculator on the computer that they have for you, which I have to look into it because somebody was telling me that they had more than just like, you know, like Jatara had was just kind of their simple function. I thought it had a few additional things, but I could be completely wrong at this point. And you can, I mean, doctors use all different ones. So, but it's good. Like I said, it's good to know the other ones that are out there. So that's why I just wanted to introduce that one to you so that you know. So we'll probably still use the 60 mils per kg per day. And then I'll also utilize this so you just are comfortable with it. But yeah, don't worry too much about it. So you're right, 630 mils in 18 hours, Hannah, good job. So what we're gonna do is we're gonna break this down, 840.4 mLs, divide it by 24 hours so that we can get an hourly rate first, right? Because we wanna figure out how many mils in 1 hour we need and then multiply it by the 18 hours, right? So we know how many mils we need in 18 hours. So 840.4 divided by 24 hours is 35 mLs per hour. So then if we take 35 mLs per hour times 18 hours, now we will know how many mils we're going to use in 18 hours. So now we have 630 mLs per 18 hours. So that's how much we need for that. So now we have all three answers that we need, right? The DOM, right? So now we can get to this guy, which I need room. I need room. All right, I'll just put it here. DOM. So we are going to take we're going to add these guys all up. My computer is so upset right now. So we are going to take 944 mLs plus our 225 mLs. And then we are going to take this last guy here, the 630 mLs, and add all of those together because that's how much we need to replace in the next 18 hours.
$17.99.
$17.99. It's like, nope, you don't get to write that. Ugh. All right, so 17.99. It'll come back. See, it's like
I got 121. 1214.
all right, so let's take a peek at it. So 944 plus 225 plus 630. Where does 630?
Oh, from the last one.
Yeah. So 17.99. See if it lets me erase it. It's like technology, seriously. 17.99 mLs. Okay, per 18 hours. So now we need to figure out, remember, our hourly rate. So what do we do?
Divide by 18.
Divide by 18. So 17.99 mLs. Divide that by 18 hours. And we get
99.9.
Oh, that's so crazy. 99.9. You want to do 100? Or do you want to keep it?
Yep. Nope, let's do 100.
100 mLs per hour. I was like, if you want to keep 99.9, I'll know what kind of person you are.
Nope.
Awesome. So 100 mLs per hour. All right, so let's do a drip rate. So we have 100 mLs. And we can put in our, I'll let you guys do this. I'll let you guys do it. So put that together.
I did not get 17.99. Did you just add a point in the middle of 17.99?
I'm stuck on the drip rate. I'm missing something.
I got it. I got it. It's a weird number. Let's see if anyone in my chat got it. Where's my chat? Where's my chat? All right.
I got something. My numbers are different because I don't have the square root. I use the
use the other
60,
guy?
the 60
Okay.
ml. Yeah, so I don't want to. My numbers are way different.
Got it. Got it.
Yeah, me too.
Okay. What'd you get for your hourly rate at the bottom, since your maintenance is a little bit different?
I got 94 mLs per hour.
Okay, so it's not horribly different at the end. So I mean,
yeah,
it's interesting to me that the maintenance rate for the day is so different, but if I guess we consider the hourly rate, I don't know. It's interesting. It's interesting how 2 drips per second, but really, or 2 drips per 5 seconds, but really, is it 2 drips per 5 seconds? I don't think it was. Because it ended up being 0.416 or something like that, right? I'm being a stickler. All right, so yeah.
So now that we're at 100 milliliters per hour, you want to figure out the drip rate?
Yep.
Okay, that's the part where I block, where I'm like, I have no idea what I'm doing.
Yep. So we have to change our hours to seconds, right? Because we need drips per second. So this is where we take 100 mils over 36 seconds. All right. So who wants to do this? Wait, who's my person with the two drips per 5 seconds? I forgot already. Where are you? Where are you? Michelle. Michelle. She's like, no. So we have 100 mils over 3,600 seconds, right? Because that's what's in the hour. And then what is our drip set we're gonna use here? Because that's all we have to insert.
The macro
Macro, good. So what's our macro set?
first 15.
15, good. 15 drops per mil. And so our mils cancel out, and that leaves us with drips per second. And so doing our calculation, we do 100 times 15, 100 times 15, oops, divided by 3,600. So what do you guys all get for that answer?
841.
It's 0.416 or something?
Yeah, something.
Okay. Drips per second. All right, so now we get to play with numbers. So what do you multiply? Oh no. So who multiplied by what? It's like, who's the winner here in multiplying numbers? Well, this is what I'd like.
So I did 0.4 times 3 and I got 1.2. I don't know.
Okay.
So
you can't end up with a point something in the end. So you have to have a whole number. So keep multiplying by an increased number then to figure something out. So increase your numbers. But you're on the right track. It can be over 1, like in your top number. So
oh, okay. Okay.
yeah. So you went to 5?
Oh,
Yeah, I got 2.05.
And then you got 2 over 5. Okay, but if you did times 5, so 0.416 times 5, what do you get? Now this is me being picky.
2.08.
Yeah. So can you get, so that's fine, right? I mean, that's close. But can you get something really with your entire number of 100 times 15 divided by 3,600? Can you take this number that you have here and multiply it by a number and get a whole number? Take that number times 12 and get a whole number.
15 times 12?
Oh, Beth did it. Times 12, you get, oh goodness, but she can't do this. Let's just do it. Times 12 equals 5 drops per 12 seconds. I would totally take your answer though, of 2 drops per 5 seconds, you said? That's close enough. But if we're gonna play a little math game.
Question.
Yes. I just try to have fun with it. Yeah.
So for your 100 mils, you have your 3600 seconds, and then you have times 15. Is that what you did?
Yep.
I did it.
Oh yeah, because I get a little crazy.
I don't know if I'm getting mixed up because there's too much writing around.
What are you
I don't
saying
get
here? I write too much? Yeah.
I
So
don't
your
get
answer, I'm like those crazy teachers that write on the whiteboard like a nut. So yeah, so your answer here is 0.416 drops
How
per
did you-
second.
How did you get to that though?
We took 100 mils
Mm-hmm.
times your 15 drops per, and then divide that by the 3,600 seconds. Or you could do 100 divided by 3,600 times 15. Either way is fine. You can interchange that.
100 times 15. Okay, that gave you 1,500. And then divided by your 3,600.
Mhm.
3,600.
Yep. I know. I wish I was a better writer. So I apologize. Plus I'm writing like with the tablet sitting straight up because I have.
Oh, and that's how you got your 0.416.
Mhm.
Drops.
And then we need to play with numbers to get our whole number. So Molly and everybody else, they settled with 5 seconds.
Oh, and that's how they got their 5 seconds, because they
Yeah.
did 0.416 times whatever.
Correct.
Okay,
Correct.
gotcha. Makes sense.
So I always make it a game of who can get closest. Oh, Michelle did 5 joules per 12 seconds. There you go. See? Everyone's a winner in the end. I have to try to make it fun. Virtual candy to everyone. Oh yeah, Jatara, what'd you get for joules per second for on yours?
Oh, I got, so I ended with 0.391
Okay.
drops per second. And then, I don't know if it's right, but I had 1 drop per 4 seconds.
Okay, so 0.391 you said?
Yes.
Times. So I
But
would
that's not right.
say, so times by, I would say you'd have to multiply that by, so if you times that by 5, you're almost at 2 drops per 5 seconds.
5.
Yeah.
Yeah, it's 1.955. Yeah.
0.391 times, what'd you get? I got 3. Oh, you rounded to 4. If you do 1 drop per 3 seconds, that's still 0.333. So you're a little short on that. If you did 2 drops per 5 seconds, that would be a 0.4. So you'd be right on the money. So I would say that would be closer in the end. I mean, that's being super nitpicky. So I would probably go with that, if that makes sense. I know it's like going back to elementary math, which for many of us is a very long time ago. of turning decimals into fractions again. So so yeah, I think that we don't realize when we go into veterinary medicine how much math we actually really do. So
Yep.
it's a big wake-up call to all of us that math and science are very key.
I finished high school and I was like, yeah, no more math. And then I went,
yeah,
great. Here you are again.
but once you get it and you do it a lot, you know, it's really not that bad. And you find little tricks to make it easy for yourself. So it's not too bad.
I see a lot of practicing in my future. This is CRI.
Yeah. No, absolutely. Practice. And, you know, just making up practice questions for yourself is really good too, or you know, things just in your work, if you are currently working, you know, just doing those math problems alongside your doctor, like just asking them and say, I hope this doesn't bother you, but can I just do them along with you just so that I get more proficient at it? They probably won't matter. Oh my gosh, you were in 6th grade in 1967. That's so awesome.
I'm actually starting to like doing CRIs.
Yeah, no, it's great. It really is great. And you know, it's a lot of fun to be able to do them and to just get better at it. So
I'm just excited to do them because like I can figure it out.
Yeah. Yeah, and there's a lot to learn from them because you learn the drugs better, you understand why they're working, and you then understand like how you can turn them up. I'm not gonna call you grandma, don't worry.
Actually, Beth, I have a really quick question.
Yeah.
It's probably a really stupid question. So with the anesthesia, the rebreathing and the non-rebreathing, so is the only difference between the vein circuit and the F circuit is that one is for one and one is for the other, since there's like a tube inside a tube, like they both have? Does that make sense?
Yeah. Yeah. So the F circuit, yeah, has the tube, right? The tube inside the tube and creates less dead space. Yeah. And also that humidity aspect to the air, which is really good, obviously, for them to be able to breathe in some more humid type of air, I guess. So it's not super dry. And hopefully be a little more, I guess it's not necessarily heated, but it's a little bit warmer per se. But yeah, so that it, there's a little less dead space, and that those F circuits come in different sizes too is really good to know. So yeah.
I was reading in the book and it said the vein tube and the F tube are the ones that have like the tube inside the tube, so that just kind of threw me off. But it's just one rebreathing and one is. Yeah,
so you'll notice that when you see them, it'll have like a blue or a green tube inside that outside tube. And so it's essentially there to create this like humidity aspect of space for the air to get through. So that's the main reason behind it. Yeah, it's hard to be able to explain it, I think, in text. So when you see it, you'll understand.
Videos.
Yeah, no, absolutely.
Yeah.
Yeah.
Okay, so just to make sure that I understand, the goal with the drops per second is to try to get the number as closest to a whole number.
Yeah.
Okay.
Yeah, you want it to be as close as possible to everything, without like rounding as much as possible, just because if you continue to round within your problem, you're going to end up changing the overall milliliters per hour that you're supposed to give, your fluid rate. So you want to try to keep it as close as possible so that you don't change your fluid rate or how much you're supposed to give within the day. So that's the huge reason why we want to keep it as close as possible. I mean, there are some people that would take, your drips per second, just multiply by 10, which in this case would probably be not horrible. But we could do better, so precision sometimes is good. So
okay, thank you.
Yeah. Any other questions that you guys came across throughout the week?
This question was kind of like a dehydration/CRI question.
Okay.
Is that what like the question we just did?
Yes, this is their dehydration, ongoing losses, maintenance, all of that. So yeah, those dehydration ones. And then yeah, we've done those CRI ones.
But like with this question here, what part of it was CRI? Was it like the last?
So the CRI one we did was up here. And then dehydration is right here. So yeah, totally separate.
felt like in my notes I just jammed the whole thing, so like it just looks like one whole problem.
Sorry, I didn't hear all of that.
I said I feel like in my notes it looks like one whole thing. Okay, so
Yeah, it's two
one.
separate problems.
Okay, so your dehydration. But, oh, C already thing was with the fentanyl and the lidocaine.
Yeah,
And then the problem we just did was the dehydration.
correct.
Okay, that's what I got.
All right. Any other questions?
Can we do one more problem, but a different type? If you have time. The
Yeah.
C1V1 C2
Ooh.
problem.
Yeah.
Yeah,
Yeah, let me get to that. So, let's see. So, say we have a, we have a bag of fluids, oh goodness gracious. Let me see. So, it'll just need, okay. So we have a bag of fluids with 640 mLs that we need to make into a I don't know, 9.7%. Oh, 9.7%. It's just going to disappear on me. Solution, I'll put. And our stock is our stock is a 75%. Sorry that this is totally a mess. Stock is a 75% solution.
So you had a bag of fluid with 640 milliliters.
And we need to make it into a 9.7% solution. All right. Our stock is a 75% solution. How many mLs will we need to add to our, to our bag? As I wrote like halfway upside down. Okay. So this one would be a C1V1, right?
Yes.
So this is very similar to those of you guys who work in practice right now, who, Amanda's like, I got this, who work with like dextrose solutions, right? And that's why I made sure that I wouldn't make it like a dextrose solution. So if we do C1 times V1 equals C2 times V2, we just have to fill in these blanks. And I totally just disregard percentages, mLs, all of that, and make it just into a simple algebra problem, because that way we just make life easier. So what we know right now is that we have a 640 ml bag of fluids. So our new bag is going to go over here. So the volume that we have is 640 mLs, right? And we want that bag to become 9.7% solution, right? So the new product is going to be 9.7% solution. So that's going to go here, 9.7, and then I'll just put percent there because I don't really care about it. Our stock product is 75%, right? So that's our current one. So 75%. But do we know how much mLs or volume that we need from that? Or is that what we're trying to figure out?
That's what we're trying to figure out.
Exactly. So we'll put that as X, right? That's our question mark. So now this becomes just an algebra problem. Like it's like, nope, you can't have your X. You got to go away. So how do we figure out this algebra problem then?
You need to isolate.
Good. Yeah, we isolate it, right? So what's our next step? You guys want to do it?
Divide 75%. Well, you divide your 75 by 75, so it cancels out.
Okay.
And then you do it on the other side.
Okay. Perfect. Perfect. Do you want to first multiply these together and then divide, or do you want to just divide out? It's up to you guys how you do it. So
I multiply first.
You multiply first, yeah. So yeah, I just simplify it and then multiply. So it's up to you guys how you end up doing it. But you're right, Melody, that you end up dividing that 75 and isolate that X. So so go ahead and do that, you guys, and then tell me what you get. So I'll go ahead and multiply these guys together too and work on it. And this is a 0.7.
I got 82.7.
So here, so 240. Oh my gosh, this is really annoying. So 9.7 times 640, what'd you guys get?
6208.
Okay. I just can't do math, I guess. 6208.
That's why God invented calculators.
I know. I did it on the calculator. I don't know why I pressed. And then you take then you're going to divide that by the 75. So divide that by 75 on both sides. And what do you get?
82.7.
Awesome. So X equals 82.7, or I guess we could say 8 because there's like, you can round it, mLs. So that's how much we're going to put into our bag of fluids, right? And we decided yesterday too, before we put that 82.8 mLs in the bag, we're going to do what?
Take out 82.8.
Take out.
Yeah, take out 82.8 mLs of the fluids and put it in there. Beautiful. Does that make sense? Awesome.
There's something that I screwed up.
I feel like C1V1, everyone always says that that's like their nemesis. So
I always put the wrong side.
And the wrong side.
That's the problem I have too. Trying to figure out which side.
Yeah, that's why I try to set it up like this and then go, okay, if I put this side as what I want it to be to end up as, end up. And then this is like what it currently is, like what is the current status, right? Of the solution, like current solution. Right?
I read it wrong.
And then I can say, all right, now we can put it where it needs to belong. So
okay. Because I guess the way I thought it is you have the 640 ml and you have the 75%. I guess is what I thought in my head. Is
yeah. And then right. And then think, okay, so if I think about it, the fluid bag that I have, right, is 640 mLs. And I'm trying to make that 640 ml bag, right? It's filled here, 640 mLs. And my doctor says, I want that thing to be 9.7%. But the little tiny bottle here is a 75% concentrated solution. So like trying to draw that picture in your mind. And then how many mLs, X mLs, am I gonna draw out of there to put into here?
That cleared it up so much. I don't know why.
And then, yeah, and then try to put it into this problem, right? So that way you know, okay, here's my C1 times B1 here, and C2 times B2 here.
Okay.
So
So
with your 82.7, what are we taking out? Are we just adding?
so you're gonna take out 82.7 or 82.8 mils of this guy right here, right? And then you're gonna put in 82.8 mils of your stock solution of this right here.
So you're taking it out from your 640?
Right, right. So you'll end up having technically 640 minus 82.8. So it'll end up being 557.2 mLs of, you know, your fluids, your bag of fluids, and then 82.8 mLs of your concentrated solution in that bag. Because you can only have, remember, 640 mLs total in your solution. You can have more than that.
So you would have minus 557 if you take it out, right?
So you'll have 557 mLs of, this will be of fluids. And then this will be of stock solution. And then when you add those together, that will total up as the 640 mLs that you're supposed to have. And that makes up your 9.7% solution. Because if you don't do that and you just add the 82.8 mLs, it doesn't make up a 9.7% solution. It actually makes up like, you know, it will probably be like 9.3% or something like that. So it wouldn't be a total 9.7% solution, if that makes sense.
So your X, so you have X equals 82.7, yeah, which is what I got. And then you're doing divided by 440?
No, this is an equal sign. Because I'm adding.
Like you have like a line underneath your X and your...
This?
Yeah.
Yeah, this is an equal, not a divided. Because there's a plus.
Oh, equals your 640.
Yep.
And then you have your 557 fluids, and then you're saying that.
Yeah,
you
557 plus 82.8 equals 640. All right. Any questions? Any comments?
Thank you very much.
Yeah, a lot better after.
No, that's good. That's good. Anything else that you guys can think of? I know anesthesia and pharmacology are a nightmare. They're really difficult. And that's why I put them in the beginning, because that way you have the entire 8 weeks to go back to them. And I know if you didn't get all of it done, then you can kind of filter things in and go back to it and practice more and more and more. So there's a method to my madness. I swear it's not to try to break you or anything. And then it does get, I'm not going to say it gets necessarily easier, because everyone has their areas where they excel in, and then areas where they feel like they need help in. So you guys can always reach out to me if you have questions. I know many of you do already, so please never feel like you can't. So just reach out to me any day. There are people that reach out to me every single day. And that's great. Even about nutrition for their own pets or something like that. So it's great. It's all learning experience. Yeah.
I can't remember if you said this in the beginning or not, but the EKG were those the practice ones that you have on Facebook as well? Do you have like on there?
Yeah, so there's additional ones on there too, where I talk about ECG in a little bit more depth too, and there are additional practice things in there as well.
Okay.
And then I do have additional things throughout the 8 weeks that will do more ECG things for practicing, so that you guys get more practice and help in. So this won't be the only time we touch base on it, believe me, because they're difficult. They're difficult to understand, and then I want you guys to know at least the basics on it. So, yeah. So we'll go over a lot more. And
I'm
then
back, sorry,
you're back, yeah. But yeah. So and then there'll be certain weeks that it won't be as crazy, and you'll have additional time to be able to go back to other things too. This week for surgery, just to warn you, there's a lot of like little videos to go through, and there's some assignments, of course, but a lot of it is like resource videos of like how to scrub, how to do this, how to do that. So it's just to make sure that all of you guys are on the same page of how to do certain things. And that way you can be like, that's not the way that I learned it in school. So we can have discussion-based things on it too. Or, hey, yes, that is the way that I learned in school. We're on the same page. So just to let you guys know, so you're not freaking out when you see a long list of things that you might not necessarily feel like they're assignments, if that makes sense. Also, there'll be a review on surgery instruments as well. So if you feel pretty strong in surgery instruments and you know them, just go ahead and go for it. But if you need a major review, there's quite a bit of surgery instrument review in there if you need it. So take it as you need it. But yeah, let me know if you need help. So anything on your guys' end? I don't want to leave you hanging.
I think I'm good for today.
Good, awesome. All right.
Great.
Well, happy birthday again, Jamie. Hope you had a great day yesterday. And I will talk to you guys throughout the week. And next weekend as well, we will meet back here on Zoom again, as this worked pretty well. I think my computer just is angry at me. So, and I will talk to you through the week. Nice to see you all in your faces, and take care.
All right.
Thank you,
Bye,
Beth.
Beth.
Bye.
Bye, guys.
Bye.
See ya.
have a good day, everyone.
Bye.